attendees. I am Dr. Kajal Jain, the organizing secretary of Academy of Regional Anesthesia National Conference 2020. So I'm hosting you today and I'm happy to greet you all to this virtual seminar hosted under the auspices of Academy of Regional Anesthesia India by Department of Anesthesia and Intensive Care Postgraduate Institute of Medical Education and Research, Chandigarh. This webinar is in lieu of the 10th National Conference, which was to be held at PGI Chandigarh, but could not due to unprecedented circumstances. I request our respected chairman of the department, Professor G.D. Puri, to declare this two-day academic event open. Professor G.D. Puri is currently our Dean Academics at PGI Chandigarh, and I'm proud to announce that Sir is spearheading the COVID operations at PGI Chandigarh too. Over to you, sir.
Good afternoon, good evening, and good morning. I'm sure Dr. Kajal has done a great job in organizing the Aora 2020. Unfortunately, the COVID prevented us from meeting each other physically, or I should say personally. But still, Dr. Kajal and her team has managed this show this evening and also tomorrow morning. And I am very proud of my department colleagues who have helped her so much. So in spite of all difficulties and our alumni and the members, lead members of the Indian Association of Regional Academy of Regional Anesthesia, who have helped in bringing this virtual platform, and we are meeting people all over the world, and they have brought out this elaborate, I won't say hands-on, but sort of hands-on workshops even in those lectures. As you know, this has been unconventional year with the globe under the rage of COVID-19 pandemic. I never thought that this is going to be so bad. When in the first week of February, one of my Italian colleague, he came here and he was literally, little worried that he had to organize a total intravenous anesthesia later part of the year. And when he said, well, Dr. Puri, will you be able to organize the International TIVA conference? I said, no problem, I will, don't worry. Even if there's he said the things are not good in China, things are not good in Italy. I said, don't worry, it won't be bad in India. But I never anticipated that what's going to happen to us in the another 2 months. And that's the situation that we are in at the moment. As intensivists, we have led the healthcare in caring for the sickest of the sick and fearlessly, religiously, and above all motivated. You will all agree that the the COVID-2 pandemic has changed the healthcare forever. Not only the healthcare, but the way we are living today. As somebody was saying that we have stopped traveling, we are webinaring all the time, and we are trying to decrease the exposure both with the patient as well as the suspected patients. So regional anesthesia has become the standard of care for providing surgical anesthesia and post-op analgesia in many hospitals. Otherwise also, but this has changed, has affected more intensely in this current COVID era, where anybody won't like to generate or produce a aerosol generating procedure. Though over the years, this regional anesthesia has witnessed exponential rise in with the era of opioid-free anesthesia, ushering in enhanced recovery pathways, facilitating the fast-track surgery and discharge from the hospital using regional anesthesia techniques. It has become a unique benefit of regional anesthesia, not only in improving the recovery, but also promoting the conservation of the personal protective equipment, which is always in short supply in the current pandemic. It decreases the risk to the healthcare workers while avoiding the aerosol generating procedure. The relevance of this webinar is remarkable in terms of updating oneself and also in learning the new norms of practicing regional anesthesia in this pandemic. And to bring the best scientific updates in the field of regional anesthesia, our organizing team has done great efforts by, along with the national leads. Few of them are our own alumni, namely Dr. TVS Gopal, Dr. Bala Venkat, Dr. Deep Arora, and a commendable job they have done. That in spite of all those things, they've told me that around 1,000 people are watching this webinar all over the world. And the program which they're having gone through this finely curated program of this 2-day webinar, I'm confident that all the attendees would take away valuable clinical pearls for their day-to-day practice, as well as have a golden opportunity to ask their doubts while sitting at their homes. With this, I welcome you all to the webinar and declare the webinar open. And I once again congratulate Dr. Kajal and his team, her team, for giving them opportunity, me opportunity to interact with these luminaries, and also being a part of these proceedings. Thank you.
Thank you so much, sir. Now I invite Dr. Vrushali Pandey, President, Academy of Regional Anesthesia, India, to address the audience and give us a go-ahead for this webinar today. Dr. Vrushali, over to you.
With pleasure. Namaste. Namaste, every person who's watching our webinar today. A very warm welcome to this gracious afternoon, which shall soon bloom into a pleasant evening. I am so glad that this event has actually manifested and truly delighted to be a part of it. I firmly believe that we do not have any luxury, no, not a single negative thought should be really entering in our minds. We don't have that luxury currently, no matter what the external conditions today may be. Today is COVID, tomorrow maybe something else. But however, as the norm gets, everything passes. So this too shall pass. On a positive note, AORA, the Academy of Regional Anesthesia, true to its mission, continues its job, continues learning, teaching, and researching regional anesthesia through webinars, very dedicated webinars, which happen every 15 days. And we have a strong educational committee, the e-education committee, as we call it very fondly, to look after it. What is even more interesting here is a very focused fellowship class that happens again after every 15 days with the mentors and their students. This is extremely structured and it's going in a direction which is very, very helpful to the students who are our futures and have an extremely curious and inquisitive mind, and which is so heartening to see. Well, this is all happening because I guess the subject is fascinating and it's totally fun. It has always been a boon, and it is proving to be a bigger boon in current circumstances right now. Well, my heartfelt thanks to PGI Chandigarh for having taken this onus. Professor Puri and Professor Kajol, I'm extremely thankful to have you taken this initiative. This was meant to be a very, very jubilant meeting, actually, and now it is a virtual event. However, the essence of it remains the same. Never mind, just the external manifestation has changed, and I'm sure we are going to have equal enthusiasm and equal fun doing it. So thank you, friends, and thank you everybody who has logged in and who shall continue to log in till the meeting gets over. I welcome you all. I also want you to be with us even tomorrow, a personal, very warm welcome. So stay with us, stay tuned, stay tapped in, stay enthusiastic, curious, and yes, above all, stay challenged. Thank you.
Thank you so much, Dr. Vrushali, for that very energetic note. And I think we will carry this energy forward. And now I request my colleague, Dr. Jitender, to take over and start the session.
Good evening and good morning, everyone, depending upon which part of the world you are at this time. Obviously, good morning for my colleagues in the United States and North America, and good evening for colleagues in India, Hong Kong, and Sweden. I'm very happy moderating this webinar today on nerve plexus block, the paths to perfection. We have several renowned speakers with us today, and I will be introducing them as we go along this webinar. All along this webinar, we will be allowing our attendees to ask questions which can be put on our social media or sent through the chat box. I would also request you to place the name of faculty to whom the question is addressed before putting in that question so that we are able to address the question straight forward to that faculty. So we start the day by discussing staple of upper limb block, the brachial plexus, also called the spinal of the arm. We all know that this is go-to for everything from shoulder to digit surgery. And who else better than Dr. Karmakar, well known in the field of regional anesthesia, to do this? Sir has got an extensive work in all the subspecialties of regional anesthesia. It's the backbone of several societies of regional anesthesia, to name a few: NISORA, ASRA, ISRA, ISORA. And I am proud to announce that he is associated with Academy of Regional Anesthesia, and we view him as our mentor. Dr. Karmakar will talk about ultrasound guided imaging of individual elements of brachial plexus above the clavicle and recent refinements in the brachial plexus block. Over to you, sir. Dr. Karmakar, sir, over to you.
Yes, can you hear me?
Yes, sir, we can hear you.
Mute.
Just a moment. Okay, thank you, Dr. Kaur, for the very kind introduction. Good morning, good afternoon, good evening. Namaskar, vanakkam, and Sat Sri Akal to all of you. It's really a great pleasure to be here and sharing some of my experience on a topic that I have been researching recently. And you may wonder, what more is it there to the brachial plexus? I will leave you to judge for yourself at the end of this 30 minutes if you feel that there is anything more that you need to take away from this talk. Before I begin, I also like to commend the Aora, the executive committee, the organizers in Chandigarh for undertaking this webinar and for your contribution to education in India. I'm very proud to be associated with you. I have nothing to declare. My tip for you attendees is that whenever you see this red star, that's an important take-home message. There will be around 10 or 15 take-home messages. If you take 5, then I've done my job. Now, I would love to be in a place like this, but today we need to sober down in this very unprecedented times. So now take a quick look at the glimpse at history with regards to brachial plexus. Actually, it was 42 years ago in 1978 when Lagrange actually described the use of ultrasound for brachial plexus sonography. But actually, it was not the use of 2D ultrasound, it was the use of a Doppler ultrasound probe to identify the subclavian artery. It was almost 16 years later, in 1994, that Stephen Capral described the first use of 2D ultrasound to describe the appearances of the brachial plexus at the supraclavicular fossa. While Stephen Capral and the likes of those stalwarts at the time get most of the credit, I would think it'd be unfair not to place credit to Dr. Ting and Shiva Ganaratnam from Singapore, because even earlier than in 1998, they had used 2D ultrasound to evaluate the spread of local anesthetic during an axillary brachial plexus block. Our experience at the Chinese University of Hong Kong in the CU Medicine has been since 1998, when the first report from my institution came on the use of brachial plexus sonography in the American Journal of Radiology. The first description of the use of ultrasound for brachial plexus sonography was by Shepard. And as you can see, it is pretty much the time that we took up the use of ultrasound. So radiologists are actually a little bit slower compared to us in taking up ultrasound for brachial plexus sonography. What Shepard did is he did ultrasound scanning in different axes, the transverse, sagittal, and the coronal plane, and he compared these images with CT and MRI to correlate the observations. And this was done in early as 1998. In the last many years since the initial description, a lot of changes have taken place. I think foremost, you got to take into account the recent advances in ultrasound technology, particularly the development of hardware, software, and imaging techniques that many researchers around the world have developed to achieve this. I have, again, no financial interest in any of what I'm saying, but these are some of the equipments that we have been using to produce some of the images that you are going to see today. This is the via equipment grant from my university that we got in 2013. And very recently, this is the Rolls Royce of ultrasound in the current day. So I would like you to sit back, relax, and enjoy this 30 minutes of presentation where I'm going to talk to you about how to perform a systematic ultrasound examination of the brachial plexus. Now, when you perform brachial plexus sonography, I would ask you, do you do a systematic approach? I think I know the answer. How do you identify the individual elements of the brachial plexus, particularly the roots of the brachial plexus, the trunks, the divisions, and the cords? Now, do they really matter? Hopefully, at the end of this talk, I will illustrate to you that they do matter. I will introduce you to some new concepts and discuss some new targets for brachial plexus blockade. In the interest of time, I will limit my talk to above the clavicle. This is an anatomical image that most of us learn from the day we start our journey in medicine. Sorry. Oh dear. There's some gremlins have creeping up. Okay, so the brachial plexus formed by the ventral rami of C5 to T1, the joint to form the trunks, the three trunks. The three trunks divide into anterior posterior division to form the cords. Since we are focused around the above the clavicle, we will talk most about the ventral rami and the trunks of the brachial plexus. Now, these are the ventral rami. Now, it is important to mention that when you talk about the roots of the brachial plexus, they are indeed the ventral rami of the cervical nerve roots. Now, often they are misquoted as cervical nerve roots. Actually, the cervical nerve roots are intraforaminal. As soon as the nerve root emerges from the foramen, it gives off its dorsal branch, and these are the ventral rami. So the cervical nerve roots are not actually visualizable using ultrasound because of the acoustic shadows of bone. So you can see the ventral rami joined together. C5 and 6 form the upper trunk. The C7 continues as the middle trunk, and the C8 and T1 continues as the inferior trunk. So now there are lots of oval and round structures that I'm going to be showing you, and let's try and define each and every individual structure that we are looking at in a more objective way. As you will see here, when you do a transverse oblique scan of the brachial plexus above the clavicle, this is the most common imaging plane that we use. You can see that there are round to oval hypoechoic structures between the scalenus anterior and the scalenus medius. This is medial, this is lateral. And in this presentation, all the images I have chosen, you will find that the reference marker will be related to laterally. Also, when you see these structures, and we do interscalene brachial plexus block, we say that we should inject close to the C5 and C6. But more important, ladies and gentlemen, it's important to say that what are these structures that you are visualizing? Are you seeing the roots of the brachial plexus? And if you are seeing the roots, which roots are you seeing? And if you are seeing the trunks, which trunks are you seeing? To make it all simple, various investigators and researchers have described the stoplight sign like you see at the traffic light. You often place the needle in plane and you aim for the two lights that are often described as C5 and C6. You place the needle in a periplexus position and you inject small volumes of local anesthetic because you don't want to block the phrenic nerve, which is located on the anterior surface of the scalenus anterior, which is not far away. And once you inject your local anesthetic, the local anesthetic spreads in the interscalene groove to produce anesthesia or analgesia of the shoulder. Now, if that were so easy and we could do this Herculean job, but the real question is, what are we really looking at and what are we objectively injecting in the periplexus position? These structures are more complex than you may think they are. They're not as simple as saying they are the C5 and C6 ventral roots. Let's take a look at this. Stephen Capral, the Pope of brachial plexus sonography, as you can see, many years ago, he described the presence of C5, C6, C7, C8, and T1 in a single transverse oblique scan of the neck. Now, it's not my objective to criticize anybody, but this is what has been published in the literature. You will see, even our good friends from Europe have described in the interscalene groove, they are labeled as the superior, middle, and the inferior trunks. And from North America, our colleagues from North America have taken a more cautious approach more recently in the 2000s, labeling that they are probably the roots or the trunks, or probably the trunks or the divisions as they approach the supraclavicular fossa. And in a review by Professor Marhofer and the group, they even label C5, 6, and 7. Now, I like you to pay particular attention to C6 and C7. As you can see that, although you can see three hypoechoic structures, are they really the C5, 6, and 7? I think for you and me to comment by looking at a single static image would be very unfair, because to be really accurate, you have to see a dynamic image. There have also been various commentaries and editorials saying that the identification of the brachial plexus roots and the trunks of the brachial plexus are more complex than you would imagine. So the stoplight sign is an oversimplification, and the arithmetics are really very complex. So Dr. Carlo Franco from the Cook County Hospital at the time did a study to evaluate in a cadaver model what were really made up the stoplight sign. He found surprisingly that it was actually what had been predicted, that maybe the stoplight sign is not really made up of three nerves. He found that the C5 root was the smallest of the three, between C5, 6, and 7. Now, I put a star here, so I like you, ladies and gentlemen, to remember that. The C6 and C7, but not C5, often exhibit intra-root splitting. Now, let me show you in this image, as Dr. Franco has labeled. He said C5 is the smallest of the 5 roots, of the roots of the brachial plexus. C6 and C7 often show evidence of intra-root splitting. Like you see, he has dissected it and it's shown that the C6 is indeed split into 2. So the contention is, if you inject between these two elements, which is the C6 and C7, then that would tantamount to an intraneural injection, may lead to a devastating neurological sequelae. So I think looking at the 3 lights is not just simply looking at a traffic light. I think you should be more objective. And how do we do that? And I think it also begs the question, have we been indifferent all these years? In order to understand this more objectively, it's important to go back to the basics. This is a classic paper by Dr. Carlo Martinoli. He described the unique sonomorphology of the C7 transverse process. This is in fact one of the most important pillars in brachial plexus sonography. The C7 transverse process has such a unique sonomorphology that it only consists of a single posterior tubercle. Actually, the anterior tubercle is either very rudimentary or often in most cases it is absent. In contrast, the contiguous transverse process with C6 has a very prominent anterior tubercle, which is indeed the Chesniak's tubercle that we all know, and the posterior tubercle is shorter. So if you remember this, the next red star here, that this is an important sonomorphological feature. On an ultrasound, you will see that this only has a single pillar. Anterior to this is the ventral rami of C7, which is the hypoechoic structure, and there is the vertebral artery, which is located anterior to it. On real time, this is what you would see. You would see the posterior pillar of the C7 transverse process, the ventral rami of C7, and the other hypoechoic structures are not nerves. They're actually the vertebral artery and the veins. So this is again another surrogate sign to you that the ventral rami of C7 is also associated very closely to the vertebral artery and vein. The C6 transverse process is seen to have a very prominent anterior tubercle. It's much smaller, and this is the Chesniak tubercle that we talk. So then you can see here that the C7 differs sonomorphologically from the C6. There's another acronym that I would like to introduce to you, the SPA, or the spa of the brachial plexus. Like many people go to a spa on a very warm day to relax themselves, rejuvenate themselves. There's actually a spa of the brachial plexus. Actually, this is the description of anatomy that was described as early as 1515 by Vesalius, and is there in all anatomical textbooks. It says the C5 and C6 join to form the upper trunk. It divides into an anterior and a posterior, like the other trunks do. The anterior trunk of the anterior division of the upper trunk joins the anterior division of middle trunk to form the lateral cord. So creating an arrangement with the origin of the suprascapular nerve as SAP. This is the classic description. Dr. Amgad Hanna, a neurosurgeon from Wisconsin, actually challenged this concept, and single-handedly, you can see he's a single-handed author, is a neurosurgeon, and he did cadaver dissections, about 15 to 20 cadavers. What he found was that the arrangement was not SAP. It was indeed the suprascapular nerve followed by the posterior and the anterior division. This was very consistent in all the cadaver dissection that he had done. Now you may say, well, really, does it matter? It may not matter to you if you are injecting local anesthetic, but as a neurosurgeon, he would often do neurotomies for various pathological conditions or treatment of his patients. So if he thought he was neurotomizing the anterior division, actually he was doing a neurotomy of the posterior division. So he also found that the origin of the suprascapular nerve and the posterior and anterior division actually not always form the trifurcation, which is the most common, but they also had an origin from the superior trunk or also from the posterior division of the superior trunk. So therefore, in general, you will find the SPA is the most common arrangement that you will see in most conditions. So let's take a look at brachial plexus sonography as described in the literature. I come back again to this work by Shepard in 1998. He documented that it's very easy to define C5, 6, and 7. Mind you, he was comparing them with CT and MRI images, but he also documented that it was very difficult to identify the C8 and T1. Carlo Martinoli was the first that described actually the T1 nerve roots, the roots of the brachial plexus. He also showed that it was very easy to identify C4 to C7. C8 he identified in 80%. The T1 was much more difficult. This is another work by Dr. Won and the group from Korea, where they showed that the arrangement of the upper trunk, middle trunk, and the C8 on top of the first rib is usually the upper trunk followed by the middle trunk and the C8. This is again an important landmark or the crossroads in the complex arithmetic of the brachial plexus. So what the lessons we have learned? The C5 is the smallest of all the three roots when you do brachial plexus sonography, and if you measure the diameters, this is what you would find. The C6 and C7 often exhibit intra-root splitting. The stoplight sign is an oversimplification and actually made up of only two nerves. So beware of injecting between two roots within the interscalene groove. It's never an objective that you should achieve or we should aim for. We always inject periplexus. The unique sonomorphology of C7 and C6 that I have highlighted to you, the SPA arrangement is very consistent. It's an arrangement that is frequently described as being very consistent observation. The C8 lies on top of the first rib and the transverse process of the T1 complex. The T1 ventral rami is more difficult to visualize, but with some of our recent work, we have been able to demonstrate the T1 more objectively. Now, with these building blocks that I just highlighted to you, let's try and reconstruct what we know about brachial plexus sonography. For those of you who have visited the beautiful country of Thailand, this is from Ayutthaya. Although it is in ruins, you could imagine how painstakingly these builders had put together these bricks. So this details can be found in our recent publication in Regional Anesthesia Pain Medicine. The rest of my presentation will mostly pictorial, so please bear with me. I will have a lot of pictures for you to look at, and I think a picture says more than many words. So the scan is usually in a supine, normal position. We use a high-frequency linear transducer. The orientation is usually pointing to the lateral aspect, which is outward. This makes identification of the images simple, whether it is a right-sided or left-sided. You will always see the orientation marker laterally, as you can see here from a lateral view. The first aim is to try and identify the C7 transverse process. So the scan begins at the supraclavicular fossa, like you identify the subclavian artery, and then you sweep the transducer cephalad in a slow sweeping motion till you identify the C7. Once you identify the C7, you then sweep the transducer further cephalad to locate the C6 and C5 ventral rami and the transverse processes. So the steps would look something like so. You would, and it's a very simple motion that you can very easily accomplish in a short while. So the first objective is to identify the C7. As you, this is just to show you the motion. It's a very simple sweeping motion that you slowly see C7, C6, and C5. Once you identify C5, you sweep in the reverse direction. Now, when you are looking at these various neural elements, it's not possible to visualize all the elements together. So your focus should be on one element at a time. For instance, if I see C5, I'm seeing what happens to C5. C5 joins C6 to form the upper trunk. Upper trunk divides into suprascapular nerve, the posterior and the anterior division. And below the superior trunk would lie the C7, which is now the middle trunk, and then the C8. So let's see if I can show you what I'm preaching. So this is how you look for C5 and C7. You start from the supraclavicular fossa. This is now, most people describe them as a bunch of grapes, but ladies and gentlemen, I can tell you, if you are familiar with systematization of the brachial plexus, you can actually identify every individual hypoechoic structure within this. So the pillar is the C7. You can see the C7 ventral rami is located very close to it. This is the C7. Let's look at C7. You can see the C7 is exhibiting intra-root splitting. This is C6. C6 is also bifid. You can see as you loop around, you can see that the C6 also becomes bifid. You can see here there are two, and the C5 is smaller than your C6. So you can see the arrangement of C6. They are actually C6 and C6. There are two, the intra-root splitting. So you can see the bifid appearance of C6 and the C7. Now, there are descriptions of the interscalene groove being like a sandwich, where you put your whatever favorite condiment. But then the sandwich of the brachial plexus is more complex. We have identified many muscular bridges between the two scalene muscle. You can see here, there's a large muscular bridge that traverses the interscalene groove. I will talk more about it as we go along. You can see that the vertebral artery is very closely related to it. Now, as you can see here, the C7, okay, this is the C7. The C6 has a very prominent anterior tubercle, and the C5 is much smaller, and this is your C5 ventral rami. So this will loop again one more time. You can see the C6, and now you can see the C5. Once you have identified the C6, the C5 is usually lying and like cranial to it, as you can see here. The C5 is much smaller, and it's the smallest of the three ventral ramis. Now let's look what happens when they fuse together to form the trunks, and then they divide into their respective divisions. You can see here, I also once again illustrate to you the intra-root splitting of the C6. In fact, you can see there are three neural elements, but actually they belong to only two nerves. So I think just to describe them as as the stoplight sign is rather oversimplification. Also, beware of these muscular bridges that exist between the various neural elements. This is again another patient in which you can see that the C6 has divided into two. The C7 also exhibits intra-root splitting. So these 5 roots, the 5 elements that you see are not C5, 6, 7, 8, and T1, as you may be encouraged to believe, but they actually belong to 3 nerves, roots. So the anatomy is more complex than you think. Let's look at the trunk. The C5 and 6 ventral rami join to form the upper trunk, and it divides into an SPA. So can we really describe it and define it? So you can see here, this is a scan where we've now identified the position where it's probably relating to the C7. You can see C7. We are translating the transducer cephalad. This is actually the same patient. So you can see here, the superior trunk has actually divided into 3 elements. This is the suprascapular nerve, the posterior and anterior. As we loop around, you can see this is C7, this is C6, this is C5. C5 and C6 join to form a larger superior trunk. They divide into 3 elements. So this is the middle trunk, and this is your C8. So you can see that as you do a dynamic scan, you can identify the 3 elements of the upper trunk, and suprascapular nerve has now become an important target for injection during shoulder surgery. And my good friend, Dr. Ban Sui, will talk to you more about this later on during this session. The middle trunk is just lying inferior to it and the C8. The next is the relationship of the upper trunk, the middle trunk that I showed you, and the C8. When you see the upper trunk, they're usually much larger than the other elements. You will also see that the upper trunk lies just on top of the middle trunk in the interscalene groove, and the C8 is usually on top of the first rib and the transverse process complex. So the formation of the inferior trunk is something that has very rarely been described, and in our recent work, we have demonstrated it. You can see here that the C8, after it emerges, lies on top of the first rib and the transverse process of T1 complex. The T1 comes from underneath and joins the C8 to form the inferior trunk and lies in the corner pocket that is described in relation to the subclavian artery. As you can see here, the C8 has emerged, the T1 comes underneath, and it joins to form the inferior trunk that lies in the corner pocket. As you can see, the sweeping motion, once you have identified the C8, if you sweep the transducer slightly towards the clavicle, like so, in a slightly up and down motion, you will find that the T1 can now be identified as it emerges from underneath. I'd like you to focus on the C8. This is relation to it. Now you can see there's another element that's coming from underneath, which is actually the C8 here. And then as you scan more anteriorly, you will see the T1 now comes from underneath. It will join, this is the T1. It will join the C8 to form the inferior trunk. This is better visualized in these stills. You can see C5, 6, and C7. You can see the C upper trunk, middle trunk, and C8. And as the C8 comes from underneath, you will see the C8 joins the T1 to form the inferior trunk and comes to lie. It comes together, it's coming closer together and lies in relation to the first rib. This is again illustrated in the same cartoon here where you can see the C8 and T1. And as the T1 comes and join, it comes to lie in this corner pocket. So actually you can identify all the ventral rami of the C5, 6, 7, 8, T1, the upper trunk, the middle trunk, and the inferior trunk as I illustrated to you. You can also see the suprascapular nerve, the anterior and posterior divisions, and the anterior and posterior divisions of the middle trunk. The anterior and posterior divisions of the inferior trunk are we haven't been able to define it because it occurs behind the clavicle, but pretty much we have exposed majority of the brachial plexus. Actually, identification of these elements are quite accurate. As you can see, when you have 3 observers, this is one of our work, you can see identification of most of the elements are very high. Inter-rater agreements are also very high. It's perfect for C5, 6 in the upper trunk And for the others, the kappa is usually in the moderate range, which is pretty good when you look at that this is a new thing. We're running out of time, so I'm just going to quickly go through a couple of things before I hand over to the chairman. Now, these have implication for safety and efficacy, as you would agree. We are refining techniques, and most of this, Dr. Ben Sui will be talking to you later. We're also developing novel blocks that I would like to spend a little bit of time talking to you about. Then this is all being done to try and minimize complication, particularly phrenic nerve palsy. And you can also, if you are able to identify these structures objectively, you can then identify anatomical variation, which are very frequent when you respect to the brachial plexus. There are also roles that this may have in the diagnostic radiology and in pain medicine, and when you're doing dynamic evaluation. So I'm just going to skip through a couple of this, if you don't mind, but I'd like to introduce you to what I believe is the future when it comes to brachial plexus sonography. Now, because you are able to selectively identify most of these neural elements, we have defined a technique or described a technique that we today describe as selective trunk block. On another acronym for you, it'll be SETB. The targeted injection of the individual trunks of the brachial to produce surgical anesthesia of the entire upper extremity, except for the medial aspect of the arm, which is supplied by the intercostal brachial nerve. That's not possible. So this could become an all-purpose regional anesthetic technique for the upper extremity, and as the chairman alluded to before, could become the spinal anesthesia of the upper extremity. In fact, the spinal anesthesia of the upper extremity is not something that we have conjured up. It's been described before, but very difficult to achieve. I now propose to you, ladies and gentlemen, that since majority of the innervation to the upper extremity arise or pass through the three trunks of the brachial plexus, selective injection of these elements can produce surgical anesthesia over extremity and would be effective not only for shoulder surgery, proximal humeral surgery, or elbow surgery, forearm and hand. So from the shoulder to the tip of the hand, you could do any surgery. And this is a work that we are currently undertaking in our institution. And this has been, as Dr. Puri alluded to earlier, that regional anesthesia has become the standard when it comes to this current pandemic in order to reduce aerosolization procedures and to minimize cross-contamination. As you can see, these are images from some of our latest patients. You can see a wide variety of things. While most investigators have talked about a hybrid technique of using interscalene combined with a suprascapular nerve block or suprascapular brachial plexus block, we have proposed that selective trunk block could be a simple alternative to a hybrid plexus block. We've also described it as a simple technique to produce surgical anesthesia of the entire upper extremity and can be useful for many procedures like this pathological fracture. Now, while you do an interscalene block, it'll be effective when you do the upper procedure. But because these procedures often involve an interlocking nail in the distal part, which is usually supplied by the ulnar nerve or the other components of the brachial plexus, interscalene block alone is inadequate. So often hybrid techniques are used. Often they are in this slightly propped up position. We sedate them with dexmedetomidine. They receive music to listen through some of the popular devices they use today, and we monitor their respiration. As you can see here, the interlocking nail has been placed, and this has become a go-to technique now to perform most procedures of the upper extremity, whether it is for the shoulder or for the hand. Sure, we are evaluating how it affects the hemidiaphragm and so on and so forth. In the future, we will talk. It is usually a 2-injection technique. As you can see here, we're performing the first injection with the transverse scan with here to inject the upper and the middle trunk. As I mentioned to you, the upper and middle trunk are very close to each other. And then through a second injection close to the clavicle, we perform a corner pocket injection to block the inferior trunk. As you can see, the superior trunk, the middle trunk, and the C8 are very close to each other. The inferior trunk is in the second window. So if you first perform the first injection between the superior trunk and the middle trunk, the second injection in the corner pocket, you can produce very effective surgical anesthesia of the entire upper extremity. This, we believe, can become the true spinal anesthesia of the upper extremity. And currently, there are a host of investigations that we are undertaking to define what is the effect on ipsilateral hemidiaphragmatic function. What is the minimum effective local anesthetic volume that you need? Currently, we are using between 20 to 25 ml of a mixture of lidocaine with levobupivacaine, but we believe that we can go down to volumes as low as 10 to 15 ml. I think there is some work with relation to this by Dr. Shivashanmugam from Pondicherry, showing that about 10 to 12 mil should be adequate. We're also comparing it with a more traditional hybrid brachial plexus block that involves using larger volumes of local anesthetic with potential for local anesthetic toxicity. With these viewers, ladies and gentlemen, I hope you would find that the systematization of the brachial plexus is truly an important concept that you should build into your armamentarium for brachial plexus blocks, whether you are doing interscalene or a supraclavicular block. I think systematization is important. In the future, you would hear more from me about the true spinal anesthesia upper extremity. Thank you for your attention. Thank you.
Thank you, Dr. Karmakar, for for detailing the individual elements of brachial plexus in such a detailed way. I'm sure our delegates would have understood the scanning of brachial plexus as good as they would have understood had they attended a workshop with the same, except for definitely they did not get a hands-on here. We have a couple of questions for you, sir. One of the delegate is asking that we don't have as as high resolution ultrasound machines that we would be able to differentiate the different trunks. So what do you think what are your suggestions? What are the ways in which nerve injury can be prevented if a person is not able to delineate all the trunks while performing the block? Is there any way that they can avoid injury to the nerve? How should they perform the injection?
I think there are two questions here. Can you hear me?
Yes, sir, we can hear you.
Okay. I think there are two questions here. One is, how does your machine compare with what we are using?
Yeah.
I think the answer is your machine is good enough to show you what I have showed you. I think the important thing is, fortunately, the brachial plexus is superficial structure. So using a high frequency linear transducer, which is available with most machine today, 12 to 15 megahertz is quite common. So using these transducer, you should be able to identify each and every individual component. What really was not making it possible to identify some of the lower component is the technique. I have showed you some simple maneuvers that will allow you not only to identify the C8, but also how to identify the T1, because the simple motion of tilting the probe from a transverse oblique to a slightly more coronal oblique when you are looking at the T1 will allow you to see how the C8 actually joins the T1 and comes to the corner pocket. So I think that's pretty much possible with all sonographic machines that you are in common use today, apart from the ones that they use for possibly vascular puncture, etc. And if you can identify these and you have the good dexterity, then I don't see any reason why you should have any neurological sequelae or complication. I think the point I alluded to is that it is important when you are looking at the interscalene groove, never to put the needle between two elements. Put your needle tip close to the nerve. A periplexus injection produces adequate analgesia or adequate surgical anesthesia. So there is no need to be more aggressive, as one of the research papers described, and more aggressive approach where you place the needle between the individual elements. That is not desirable and is not required. Thank you.
Another question we have is that is brachial plexus block with nerve locator helpful as compared to ultrasound alone? Like, is the using combination better than ultrasound alone for avoiding nerve injury in these blocks?
I think to answer that question, you got to look at it from two aspects. One is it's not an evidence-based answer that I'm giving you, but there is um, some justification why one should use nerve stimulation in the beginning. I think in the beginning, if you're not very confident in identifying the neural elements, then the nerve stimulation will provide you a secondary mode in which you can tell that this is the C5 or the C6 or other elements that you are stimulating. Secondly, when it comes to neurological sequelae, I think Dr. Barrington and the group have shown from Australia that over a large number of series cases that if you use ultrasound alone, actually the incidence of neurological sequelae is indeed quite low. So to what extent nerve stimulation would improve that, I can't answer that question, unfortunately.
Another question we have, Dr. Karmakar, is that is it possible to see posterior rami at root level and posterior divisions at interscalene region?
The answer to that is no. As far as with my skills, I have attempted it, but I can't define it. The important thing to understand is when you're looking at the posterior rami of the cervical nerve root, it actually given off almost immediately as it emerges from the foramen. So it goes posteriorly into the erectus, the posterior cervical muscles, and emerges from the foramen as a ventral rami. So when you're looking at the ventral rami of the cervical nerve root, actually the posterior rami has already been given off. So uh, from an anterior location, I don't think it is feasible today. But then nothing is never feasible. So with the techniques that we are using, we haven't been able to define the posterior rami.
Another question is, Dr. Karmakar, what is the learning curve for budding youngsters to achieve the level which you have achieved?
That's a difficult question. I think when it comes to, let's focus only on brachial plexus sonography. So if you're looking at brachial plexus sonography, what I have taught you today or what I have spoken to you today, if you have taken 5 or 6 building blocks from this and you use it in the next 2 weeks in your clinical practice on a religious basis, then your skills would be a whole lot better than what they are today. Now, don't expect things to happen overnight. It takes a lot of perseverance. It takes a lot of patience. Takes a lot of hard work. So people always want to succeed. But I always tell my fellows that there is no shortcut to hard work. If you are prepared to do hard work, you will succeed. So with that philosophical approach, I would suggest to you that you take away some of the building blocks that you will hear not only from me, but from some of the other wise men that will follow, that you can inculcate into your clinical practice on a day-to-day basis. And hopefully, a few years down the line, you'll be better than me. I hope that answers your question.
Yeah, it does. And another question, how can we differentiate between an injured and a normal nerve from an ultrasonography? Is it possible to differentiate that whether nerve injury has been done when a person is scanning at the end of the procedure?
I think in real time, it is possible because there are many criteria that have been described in animal models, in cadaveric models. But touch wood and God bless, you never see this in clinical practice. But I think important to understand that if you place a needle into a ventral nerve root and you inject local anesthetic or you inject anything into it, the chances of having neurological sequelae is very high compared to, say, when you put your needle into the sciatic nerve and you inject local anesthetic, where would be tantamount to an intraneural injection. The chances of injury are much higher in the proximal part of the plexus because there is the nerves have been described more as being composed mostly of neuronal tissue and lower connective tissue component. As the nerves go more distally, the connective tissue elements increase and therefore provides some margin of safety, as you would see at the popliteal fossa for the sciatic nerve. But when it comes to the cervical plexus, the brachial plexus, and injections in relation to the interscalene groove, I would think if your needle is intraneural, there are a few things that you may observe. One is, in real time, this is what you may see swelling of the nerve. And in fact, even small volumes as much as 0.5 cc's will be able to show you, as long as you're constantly monitoring the nerve, an increase in diameter or the size of the nerve. There may also be features of spread up and down the nerve that you may not be witness to, but increase in the diameter and increased resistance to injection are other features that have been described as clinical criteria that may indicate that you're placing the needle in the nerve.
There are many more questions, Dr. Kamakar, which are coming up, but I think because of limited time, we have to let you go right now. My question, can we request you to stay with us as we progress in the webinar so that you are able to answer more questions if we get time later on, sir?
Yes, definitely. I will be here. I'm standing between you and my good friend, Professor Rawal. I like to hear him too.
Thank you, sir. Thank you, Dr. Karmakar.
Thank you. Thank you, everybody.
Yeah, I extend a heartfelt thank for sparing your valuable time and joining us for this e-webinar. Moving on, we all know that regional anesthesia is one thing which has come up to promote enhanced recovery after surgery. Now, concept of this fast-track surgery was introduced way back in the last decade of 20th century by Dr. Kehelet. He worked on it initially for gut surgeries, but later on, ERAS Society was formed, and ERAS had formulated their protocols to ensure that there is a faster recovery of patient after surgery. Now, an anesthesiologist plays a very important role, and we have Professor Dr. Ranarinder Rawat with us from Sweden, who is going to, enlighten us on this aspect. Sir is an Indian national and is currently holding position of professor at Örebro University, Sweden. Sir is recipient of several important awards like Labat Award and Karl Kohler Award. Sir is a member of examining board of ISRA and has been instrumental in conducting IDRA exams in our country, thus giving opportunity to all Indians to give exam from their home country, which we believe is a very big thing. Sir is associated with several prestigious associations relevant to regional anesthesia and is a member of Prospect Group, thus giving procedure-specific post-operative pain management guidelines, which are the need of the time. Over to you, sir.
Thank you very much. Thank you for your very kind introduction. It is indeed, can you hear me?
Yes, sir, we can hear you, sir.
Okay. Well, again, thanks very much. It is such a great pleasure to see you, and my compliments to you and your team, Dr. Kajal, and all of you in Chandigarh, and also, of course, everybody with Aora. It is indeed an honor that I've been asked to participate. And it is, again, compliments, because it is not easy to organize this in these challenging times. Of course, as a Punjabi, I was looking forward to coming to Chandigarh and experience some Punjabi food and culture, but I guess that'll have to wait another time. And I'll also like to thank Aora, because here in Europe, when I'm participating in ESTRA meetings and others, I'm really proud and impressed with what Aora is doing. You have this dream team, Vrishali, Satish, and Dr. Gopal. Bala, of course, I see here smiling. Sandeep, this is the dream team, and I'm always impressed with what you're doing. Of course, we have ESRA and ASRA, but on a national level, what is going on with Aora is second to none. So my compliments. So good morning. Well, it is morning here in Sweden, and my topic, let me see if I can get this going. So my topic, of course, is about ERAS. Everybody's talking about ERAS, but I must say, on a personal level, I'm not that impressed. There is good evidence that if you implement ERAS protocols, then there will be a reduction in the length of hospital stay. And of course, that means reduction of costs. And there is some evidence that even morbidity, postoperative morbidity is reduced. But again, there are many problems with ERAS protocols. They can be confusing. They are rather complex, and they emphasize too much on the length of stay and not enough on what is important for the patient from the patient perspective. I'll get back to that a little later. We also have to remember that the length of hospital stay has been going down. You can look at your own institution. The length of hospital stay after a particular procedure is not what it was 10, 20 years ago. So it's not only RAS that reduces hospitalization. And of course, my topic is about the role of anesthesiologists. I will talk about the different analgesic techniques and also about, about the anesthesia techniques. Yes, ERAS is popular. As you can see, almost all major surgical procedures, they have ERAS protocols. And so it is popular, yes. But again, if I'm going to concentrate a little bit more on colorectal surgery because it is something that has been best documented. And if you look at the green points, if you like, they're all controversial. So there are more than 20 components for colorectal surgery. Implementation is a big problem. Several issues are controversial, like the use of epidural. I'll get back to that. I'll give you one other example, bowel preparation. The American recommendations are, yes, we need to do it. The European recommendations are, no, we don't need to do it. There are also controversies about goal-directed fluids, etc. So I'll get back to that too. So many problems. ERAS has been around for more than 20 years, and there are, as I mentioned, for colorectal surgery, more than 20 components. But even today, after 20 years, it is little unclear which are the essential components and which are not. And also, normally they will talk that compared to traditional care, ERAS is better. But it is very unclear what traditional care means, because that is not static. So traditional care over the years has also evolved, and many things like not having nasogastric tubes, mobilizing your patients, they are also involved in the traditional care. And also if you look at some other issues like length of hospitalization is going down in ambulatory surgery too. So there are, it's as I mentioned, not too impressive. So here is looking at a systematic review, 34 randomized controlled trials, and they have looked at how much are people following these ERAS guidelines, the compliance. And it turns out that the compliance is very, very variable. And of course, if the compliance is not good, then in fact, you lose all the benefits and there will not be much reduction in hospitalization, etc. Here is an example, and relatively recent, ERAS in obesity surgery. So you have more than 20 elements. And so they include 11 studies in this meta-analysis, and only 2 of them are randomized controlled trial. And that is the other problem with much of the surgical literature. It is mediocre quality or poor quality. And this is one example. So the inclusion criteria are 4 out of those 20 plus elements. If you have in your study, then it is included. And you can see in these 11 studies, 4 elements, 4, 6, 15, 13, etc. So it's all pretty confusing. They talk about using multimodal analgesia, but it is used in only 2 out of 11 studies. In other words, again, they conclude that there is reduction in length of hospital stay, but no other benefits. And it is not so surprising because of the quality of the literature. Another example, similar, this is 14 studies, 19 ERAS modalities, None of the studies uses all those 19 components. And you wonder, why do you have so many components when people are not using them? And then, of course, you see the length of hospital stay again, ranging from 2 to 13 days. So again, poor compliance, confusing, complex protocols, not quite sure which are essential components and which are less essential components. Here, for example, looking at discharge criteria, this is 156 studies over a period of what, 13 years or so. 70 different sets of criteria used to indicate discharge readiness. Can you believe that? This is amazing. This is so confusing, and this is after 20 plus years. Postoperative ileus, which is one of the important things after colorectal surgery. The incidence varies, again, incidence varies from 1.5% to 62%. Can you imagine that? And it all depends on how you define ileus. The cutoff is 1 to 7 days. And by the way, even today, after all these years, there is no consensus what is postoperative ileus. There's no consensus on the definition. So again, lot of confusion. And the other thing that I wanted to mention was that there is so much focus on postoperative hospitalization time and very little on what is important to the patient. For example, here it says ability to perform activities of daily living. It was studied in only 4 out of 38 studies in this systematic review. So this goes on, and as I mentioned, quality of literature is not good. Also, there is very little long-term follow-up. If you look at long-term, little long-term, you might be interested in knowing that if you follow up little longer, at 30 days, there is a readmission rate of 10%, and at 6 months, it is 20%. So, and this is not being done very much. And also I want to I'll come back to this slide a little later. It's a busy slide, I'm sorry. But the last line is what I would like you to have a look at. What I'm saying is, if you look at the length of stay, for example, this is total knee surgery. In the 1990s, this is from this enormous literature. These authors say in the 1990s, the mean length of stay was about 10 days. Today, it is, or in 2016, it was 2.5 days. So that was the point I was making earlier, that the length of hospitalization with or without ERAS protocols is gradually going down, as I'm sure has happened in your institution too. In fact, here is a study, in fact, from Sweden, where they implemented ERAS protocols. This is about 8,000 hips and about 6,000 knee surgeries. They implemented ERAS, and they are very impressed that they could reduce their hospitalization from 5 days to 3 days. But as I showed in my previous slide, the mean has gone down to 2.5 days even without ERAS. And in fact, if you can go further, this is 80,000 patients in 17 studies. They are doing, particularly in the United States, they're doing outpatient hip and knee replacement surgeries. So it is not that impressive, this length of hospitalization, which is one of the main benefits of ERAS protocols. I'm more impressed with what is happening with the outpatient scenario, if you like. The area in black is the progress of the proportion of surgery performed on outpatient basis, as you can see, has been increasing over the years, and this is 2000, but today it is even higher. So I believe more than 70% of all surgery in the United States is done on a daycare basis. And I think, this is where I would go to get my inspiration rather than the ERAS societies, because the ERAS people have really shown how you can reduce your hospitalization, because by definition, the patients are home the same day, or in USA after 23 hours or something. And also other surgeries which can be done on outpatient basis, major spine surgery, for example, this meta-analysis showing that it is safe. So the experience from ambulatory surgery is, in my opinion, quite impressive and perhaps better than what ERAS has achieved. And look at all the surgical procedures that are being done on ambulatory basis today. I think it is quite impressive. I know this is not, it is more common in the United States, but even in Sweden, about 55% of all surgeries are ambulatory, and it is increasing. And I think same is happening in other parts of the world too. And there are those, the critics, who go even further. They think the whole concept is obsolete because they think what is happening is nothing more than good clinical practice. Because if you look at what has happened over the last 20 years in traditional care too, we are not using nasogastric tubes, we are restrictive with epidurals, we mobilize our patients. So this is the same whether you use ERAS or not. And like this person says, the main problem with the term ERAS is that it infers if it is innovative, but it is not true. It is just plain good clinical practice. So what are the recommendations that we have for us as anesthesiologists? These are American recommendations. The point I would like to make here is they make strong recommendations, but you can look, the evidence is weak. So the evidence is moderate or weak. There's hardly anything which has real good procedure-specific evidence, except one here in America. This is the use of chewing gum to reduce the risk of post-operative ileus. Chewing gum is truly evidence-based. There are several meta-analyses, and so yes, it can be used. But of course, for other procedures, the evidence is not very strong, but the recommendations are strong. So chewing gum is working, it works. And in fact, is a part of protocols. I know at our institution, we use chewing gum. And the question is, and I know I talked with Henrik Kellett, a good friend of mine, just to provoke him. I said, Henrik, which is better, chewing gum or thoracic epidural? And he cannot answer the question. Nobody can, because there are no head-to-head comparisons. But it is quite interesting to see that chewing gum can be so effective. The other issue that we want to talk about is multimodal analgesia, because in the European guidelines, ERAS guidelines, and American guidelines, and all guidelines, everybody talks about multimodal analgesia. Your multimodal analgesia is not the same as mine because there are many variations. The concept of multimodal is good because you're talking about using analgesics with different mechanisms of action, non-opioids, and the idea is to have some kind of additive or a synergistic effect. The whole idea is to reduce or eliminate the use of opioids. But how is it working in clinical practice? And you can see this is from USA, 315 hospitals, 800,000 patients, looking at these 4 procedures, colon and hips and etc. And they find that almost every patient is receiving opioids, although the whole idea is to reduce or to eliminate opioids. And so the conclusion was that there's a tremendous variation in the utilization of multimodal analgesia. I know that, for example, for some years ago, gabapentinoids were very popular as part of multimodal analgesia. Today, they are not recommended. I did a literature review a few years ago, and my conclusion there was that, yes, we talk a lot of rhetoric, but there is only only evidence for one combination, that is paracetamol and non-steroids. There is good evidence that if you combine these 2 analgesics, you will get a better analgesia than either drug alone. The effects are not overwhelming, but that is all there is in the literature. The benefits of combining other non-opioids are not there. They're overrated. And the most important thing is side effects, nobody writes about it. So we don't know. We have to realize, as we all know, all drugs that have effects also have side effects. So when you're combining a lot of drugs, you can have a combination or additive effect of side effects too. So the evidence for multimodal is not good. That doesn't mean that we shouldn't use it, because the idea of avoiding opioids is still good. But in my opinion, we should be using regional techniques as the first line. So we should be, for example, in my institution in Örebro, since 1991, so it's almost 30 years, we have been giving to every single patient some wound infiltration. If we cannot perform blocks, let the surgeon put some bupivacaine in the wound and some paracetamol, and use that as a multimodal and use opioids as rescue. So again, what about non-steroidals? Depends on the surgery, but in the colorectal surgery, it has become controversial because there is a risk of anastomosis leakage with the non-steroidals. And of course, there are other issues with non-steroidals too. And here's something which is presented in abstract form, but this is some meta-analysis where they have seen a correlation between fluid restriction, goal-directed fluid therapy, and acute kidney injury. So a correlation between ERAS protocols and acute kidney injury. We need to know more about these studies, but if you're using non-steroidals and restricted fluids, then there is a risk of increased kidney injury. This is something we have to keep in mind too. And also goal-directed fluids. And that was my point, which I made earlier. Many issues are controversial. There's a lot of debate about using goal-directed therapy. And I mentioned about bowel preparation. I'll talk about epidural too. But now, a lot of studies saying that it has no real benefit. So that is the other problem. Many things that are recommended, and now they are not recommended. So here is something from the ERAS Society. This is what they are recommending, multimodal analgesia, and also strong recommendation for thoracic epidural if it is open abdominal surgery, and weak, the last line, weak recommendation for thoracic epidural if it is laparoscopic surgery. But they're also recommending IV lidocaine, which is also helpful in abdominal surgery, TAP blocks, and wound infusions. And but this is about 4 years ago, but 2 years ago, now they are not recommending epidural for laparoscopic surgery, but for open, it is still recommended, and these other procedures that are about the same recommendations. And there are those who go further, that there is increasing evidence that not only is epidural not beneficial, it can in fact be harmful. So the use of epidural is going down, and this is some data from USA showing that if you are using epidural, you have increased risk of ileus. In fact, you increase the risk of hospitalization, partly because of hypotension, some motor block, etc., and also some other complications, as you can see. So epidural is not that great. And I mentioned this slide I've shown earlier. This is a network meta-analysis which allows us to compare different modalities. So this is 170 randomized controlled trials looking at 17 different methods to treat postoperative pain after total knee surgery. And I'm not going to go into the details. There are some things are as you would expect, that opioids are not so good, that femoral sciatic and perineural techniques are very good for total knee. But the surprise here is that epidural technique, out of all the 17 techniques, epidural was inferior to almost all other techniques. Can you believe that? And so epidural, as I said, the more we are learning now about it, then we find that there are problems. And the prospect group, for those of you who do not know what prospect is, this is a group of surgeons and anesthesiologists. And we've been around for over 15 years. And the whole concept is that most guidelines are one size fits all. And we all know that say thoracotomy is totally different from pain after hysterectomy or total knee surgery. And so the techniques should be procedure specific as opposed to one size fits all. You have the link up there, which is freely available. I urge you to go to that to look at these different surgical procedures. The point I'm making by showing this slide is that if you look at all these surgical procedures, it says epidural, no, 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 except open thoracotomy. But even there, you have very good evidence that paravertebral block is a good alternative. And even and here is a yes for open, but personally in the prospect group, I was not so much for epidural there either. The guidelines will be updated later and soon, I don't know, in a year or two, and I'm not sure. I doubt if epidural will be included. So the role of epidural is going down. And what is good news is that there are today good alternatives to epidural. And I'm not talking about some which you will be hearing later today about these techniques, the interfacial blocks, etc. We'll be talking about it, the pectoralis, the serratus plane, the rectus spinae, the quadratus lumborum, etc. They are good techniques, they are effective, but they're still evolving, and we don't have enormous amount of literature yet. We'll hear more about it later. But what we do have literature, and we do have evidence that there are, and these are all meta-analysis, systematic reviews, that paravertebral is as good as epidural with low risk of side effects. You have continuous wound infusions from abdominal surgery. You have LIA, and I like to mention there is LIA is local infiltration analgesia, but the original LIA was and still is periarticular use. So it is not just local infiltration, and this is continuous wound infusions. These are not the same thing. This is LIA is only for hip and knee, but there's in the literature confusion. And TAP blocks and pre-peritoneal for abdominal surgery. And you should not forget the simple spinal technique at the time of performing a spinal, putting in a homeopathic dose of 100 micrograms of morphine can give you good analgesia if you're lucky for up to 24 hours. And these are all evidence-based modalities instead of epidural. So there are many good alternatives to epidural. And also, I'm just running out of time. And also, as anesthesiologists, obviously, we have to look at the fluid balance, heating of the patient, nausea, vomiting prevention, etc. But that is a topic for another lecture. But these are things we as anesthesiologists have to look at too. So to summarize, there has been a paradigm shift, if you like. When I came to Sweden in the 80s, I'm taking total knee replacement as an example. We used to give anesthesia and intramuscular opioids. And then, of course, the combined spinal technique, the epidural and spinal techniques. And then came, of course, the peripheral blocks, the femoral sciatic and other blocks. And now we have the LIA technique, and you may add an adductor canal block or an IPAC. So this is what has been happening. We are going away from the central blocks down to real periphery. And that has been one of the major changes, I think, also for regional anesthesia. And I want to show this slide by Henrik Kalet, who started the whole concept in 1997, more than 20 years ago. And a recent review article says it all. It says the implementation has been slow over 20 years, lot of problems. He started with 5 or 6 components. Now there are 30 components. And I think the title says it all. It sounds good from far, but it is far from good. And this is 20 years after they started the concept, more than 20 years. So my summary slide, ERAS, yes, reduction of length of stay, good. But the benefits are mainly, in my opinion, due to protocolized care, everybody on the same page, everybody doing the same thing. And we have to remember the length of stay is decreasing even without ERAS. Protocol adherence, very poor, complex issues, and no real definitions, poor literature. anesthesia, analgesia techniques I've talked about. We hate opioids, all of us, but unfortunately we can't do it without them. We should be having opiate sparing techniques. And of course, regional techniques are best. Epidural is out or should be out, and it is going down. The good news is that we have better techniques, infiltrative techniques, which I have talked about. And my last slide I will leave with you is those of you who are skeptical about global warming, here is some evidence for you. Thank you very much for your attention.
Thank you, sir, for a wonderful presentation. We have a couple of questions for you in the chat box, sir, and we would be delighted if you stay with us as the day progresses, so that we can keep on sharing more questions with you. An interesting question which has come up is, sir, you mentioned about bubble gum. So what is the dose and how frequently and how many hours before surgery should it be used to have a
Bubble gum.
have a better outcome?
It's not used everywhere. It is used about 3 times a day, and it is for about 10 to 15 minutes. When I come back, I will show you something which has been recommended. I have to look back at the slide where it did show very briefly what is recommended.
Okay, sir. And another question is, sir, what are the barriers to the application of ERAS in scheduled, unscheduled cesarean deliveries?
Scheduled and?
Cesarean deliveries, sir.
Oh, the ERAS in cesarean deliveries. Again, I was concentrating more on the colorectal surgery and the total hip and knee surgeries. But I think the barriers are the same for cesarean section as they are for others. The barriers are on a level, the surgeon's level. For example, the phalange steel incision is what we have been using all these years. Our prospect recommendations say that there is Joel Cohen incision, which is better. We also say that we should leave the peritoneum open. And the question is, will your surgeon change the routine? And even if you remember one slide I showed, it is we as anesthesiologists, we are using epidural, but the surgeons were not using the transverse incision, which was recommended for colorectal surgery. Only 25% of the surgeons were using it. So the major barrier is the surgeon who will tell you, are you going to tell me what to do? I have been doing this surgery for 30 years, etc. And that is the problem. They are not using what is recommended, and that is the problem of implementation. And it is not specific for cesarean section, it is specific for all kinds of surgeries.
Thank you, sir. And sir, is PDPH deterrent for applying ERAS in daycare surgeries?
If there is
PDPH, postural puncture headache, a deterrent for applying ERAS in daycare surgeries?
Wow, I don't know. I don't know. Daycare surgery and ERAS are basically mutually exclusive, because most of the time they may be applying some, and that was the point of my lecture was, I would rather go to look at the daycare surgery scenario to get inspiration rather from ERAS. So ERAS, daycare people don't care too much. All the daycare benefits that you have seen, how it has increased up to 70% in USA, is without ERAS protocols. So I do not know about, I cannot answer that question about this headache, because that I don't know if it has been published. I'm sorry, I cannot answer that. But I think, generally speaking, the impressive results you have seen in daycare surgery have nothing to do with ERAS, and that is one of my points. I would look at daycare surgery rather than ERAS if I were to introduce something new in my institution. I would look at what they have done with daycare surgery over the last 10, 15 years rather than ERAS, which to me is a lot of complex issues.
Thank you, sir, for addressing a very novel approach of fast-tracking patients to path of recovery. Thank you, sir. We hope you're going to stay with us as the day progresses, and we'll get back to you in case whenever more questions are coming up.
Thank you. Thank you very much.
And coming to more specific surgeries, COVID-19 pandemic has spread globally and placed healthcare system under substantial strain. There have been epidemiological evidence of patients avoiding hospitals and clinics despite requiring medical care, with significant decrease in hospital admissions for non-COVID-19 admissions. However, have a slip at home fall and they sustain a fracture. So we all know that potential delay in presentation for hip fractures are concerning given the morbidity and mortality associated with prolonged immobilization and delayed care. And who will be a better person to deal with this situation and enlighten us on the topic than Dr. Vishal Uppal, who has been one of the authors for practice recommendations of neonatal anesthesia and peripheral nerve blocks during COVID-19 pandemic. Dr. Uppal has numerous publications to his credit and is an invited speaker for many international conferences. Feather in his cap, Dr. Uppal has been recognized as top reviewer 2019 by Canadian Journal of Anesthesia. So ladies and gentlemen, I present to you Dr. Vishal Uppal, who would be talking about emergency hemiarthroplasty in elderly with COVID-19, anesthetic techniques and role of regional anesthesia. Over to you, Dr. Uppal.
Thank you for your kind introduction. Can you hear me okay there?
Yes, we can hear you.
Perfect. Thank you. It's a hard act to follow, Dr. Rowell and Dr. Karmakar, because I grew up with reading their papers, and I remember the first paper which my fellowship director handed over to me, because I was very pro epidural, was Dr. Rowell's Epidural's Gold Standard No More. And then Dr. Karmakar came to us when Dr. Ganapathy was our SUDA program director and showed us personally how to do lumbar plexus block. He held my hand, how to hold the probe, you know. So I was fortunate to follow these, but just get your expectations really down here because you're following the follower, you know, now. So I have to echo the comments by Dr. Rowell about the organization of the conference and inviting me here. And I was looking forward to the food as well. Here I'm stuck with my coffee and toast, which is fine. But I think we have to do, if life gives us lemon, we make a lemonade. And I think the organizational committee has done a very good job in doing that. And this is as good as it can get. So the topic which was given to me was emergency hemiarthroplasty in an elderly patient with COVID-19 infection, anesthetic technique, and role of regional anesthesia. So I was looking at the topic, I was thinking that elderly and regional anesthesia for hip is fairly established. I'm not going to be able to convince you if you have not been convinced about that just now. So I sneakily changed my topic to regional anesthesia for hip fracture surgery in a COVID positive patient. And at the outset, I would like to say I have no conflict of interests here. My Twitter handle is ropivacaine, but I don't get paid by any of the companies which make ropivacaine. So you can be rest assured with that. I would like to start by who am I, you know, and there was already an introduction given, but I have some interesting facts to tell you, mainly about the place I work in. I was born in Delhi, and I did my med school in Hubli, Karnataka, and then did my residency in Safdarjung, Delhi, and repeated my full residency in UK. And I was staff in UK for some time before moving to Canada for fellowship, and where I ended up staying. Now I'm working as an anesthesiologist in Halifax, Nova Scotia. And for most people who don't know Nova Scotia, it has a population of 1 million people around them. It's about 2.5 hours flight from Toronto. 17 hours drive. Okay, the distances in Canada are like unbelievable. You won't believe how far things are. So flight works out very well. About Nova Scotia, also I am the local fellowship director and also hold a cap for vice chair of the regional anesthesia section of the Canadian Anesthesia Society. But I want to talk more about Nova Scotia because we are very unique here in what we have with the COVID situation. So this is a slide I've taken from the official network, which shows the number of COVID cases. So we had fair amount of our share of COVID for the first wave. You can see that from March to May, we had the first wave where we had about 1,000 cases. That's for a million population. It's not too bad, but the success story is afterwards. If you see afterwards, we've had really no cases after it. And this is a good success story. It was covered by New York Times as well, a success story of how to handle COVID. And that's probably one of my credibilities here, although I can't take the full credit for it because it's basically public health, our politicians and healthcare, which collaborated to produce this astonishing and very happy results. You know, you can see like 1 or 2 cases throughout since May is not bad at all. And it's all to do with contact tracing and isolating the people who are positive and their contacts. So what have we been doing? Nothing rocket science, just those basic principles which we talk about. We talk about maintaining social distancing, using mandatorily mask, hand washing, limiting our indoor activities, gyms, worships, yoga centers, very tightly regulated here. We can only be in a group of 10 people here. And we have consistent groups, you know, we call it family bubble or friend bubble. So you pick up your people and you socialize with them, you know, don't socialize with too many different people. And then finally, avoiding crowded places. So that's it, you know, simple, keep saying simple, and it does work. And it shows from our example that how well it has worked. Going back to why I am here, coming back to the real talk, is because of these 2 documents which were published earlier this year. The first one is joined American Society and Regional Anesthesia Society and European Society guidelines, which I published along with my co-authors, and Rakesh was one of them who is going to be following me after my talk here. And the second one was the paper published in Anesthesia, which is a much more detailed review of the literature around regional anesthesia in just many respiratory infection. And Aora came with similar guidelines, and many other organizations came up with similar type of guidelines. But the response to this was kind of mixed, you know. The first paper talks about and was generally supportive of it, but was like, say that these guidelines are recommending regional anesthesia to avoid aerosol generating procedure is a bold statement. But they said, yeah, it makes sense to do it, but we should take patient features into considerations or patient's wishes into consideration, which I agree with. The second one was a little more skeptical about it, saying that we're not really ready to recommend regional anesthesia to avoid just aerosol generation. And you can make the decision yourself, but I'm going to go over a few things why we made those bold statements, as they were called. So this comes from the original SARS pandemic in 2003. And this systematic review describes the risk of getting a COVID infection or respiratory infection. It was not COVID, it was the first SARS pandemic that time, for people who intubated. And what they found was the people who intubated had 6.6 times the odds of getting the infection compared to the ones who did not. And people who did bag mask ventilation had about 3 times the odds of getting the infection compared to who did not. The other factors include, which increase the risk of infection to the healthcare provider, was using non-invasive ventilation and tracheostomy. But intubation was the top one with the odds of 6.6. And more recently, the Intubate COVID study, that showed that 1 in 10 healthcare provider who provided the intubation had a positive COVID outcome. So pretty convincing to me, but let's go over this, It's been a debate going over and over again, and there's been an infodemic since then. These are the two papers from the same journal, Anesthesia, published in the same month, which is this month, October. The first one says that intubation is not aerosol generating, but extubation is. The second one says that both intubation and extubation are aerosol generating. So what is aerosol generating? What is non-aerosol generating? I don't know. I think I'm going back to what Dr. Rao was saying. We don't know and what the standards are, and literature is so poor on it. And on top of that, just because you can find a viral RNA doesn't mean that virus can be transmitted that way. So I don't know about you. I've been following this evidence very closely, and I'm at the stage where I feel like this, I don't know what's going on, So what should I do when the information is so much and it's not consistent? So what I do is I go back to WHO because I find their guidelines as really reliable. And this is about transmission of COVID. And was published in July, but I've been talking to my local experts, which I really trust because our success story is because of them. And they really feel that this is still valid with all the extra information coming here. So what it says is that current evidence suggests that the transmission is primarily by droplets and contacts, although aerosolization can be a possibility in certain medical procedures, similar to intubation. So I think it's fairly convincing. We don't know whether intubation is aerosolizing or not, but it's probably best to treat it as an aerosolizing procedure. And for that reasons, I think it's best for healthcare worker to avoid intubation if possible. If possible, that's a big question. That's about the healthcare worker. What about the patient? And I really like this study, which was published earlier this year in Lancet. It comes from the COVID surge group. And I really appreciate them, and hats off to them, to recruit 1,000 patients in the peak of pandemic, perioperative patients who were getting surgery. And what they found was the 30-day mortality was 23.8%, which is fairly high. And risk of pulmonary complications was 50%, which is again astonishingly high. So what were their final recommendations? They came up with recommendations we should consider postponing surgeries, but also they came up with the factors which were associated with higher risk of mortality and higher risk of pulmonary complications. And these were males, older age group, Higher American Society of Regional Anesthesia, ASA classification grade, malignant disease, emergency surgery, and major surgery. And if you notice, all these factors are not modifiable. You can't change the sex of a patient. You can't change the age of the patient. You can't change a malignant disease to benign disease. So these are non-modifiable. But when we looked at their data closely, what we looked at was the risk of mortality and pulmonary complications in patients who got regional anesthesia versus those who got general anesthesia. And looking at their data themselves, we found that there was favorable effect, although it was not significant, so you can argue about it, but the odds were like 1.2 in favor of regional anesthesia. So it might be actually one of the region modifying factors. In any way, it's not worse than general anesthesia. So there's no question that regional anesthesia might be better from the healthcare perspective, as well as from the patient perspective, and with all the other advantages it comes with. So we have a patient in front of us now who has a hip fracture, so hip fracture, needs a surgery. So we've asked a few questions as to how we can make the best decisions for the patient. So first thing we have to ask is, can we wait or can we postpone the surgery, as shown in the previous slide? And we know that for a hip fracture surgery, it's probably not best to wait for them. They'll have a poorer outcome. The next question we have to ask is, can we avoid an aerosol generating procedure? And that's a simple answer. The only way to do that would be a regional anesthetic technique. And the next question is, what regional anesthetic technique? And I would say that spinal anesthesia is fast, safe, in most hands, and most people can do it. Most anesthesiologists can do it, not people, I must say. But we have to watch for any contraindications, because we know that some people who have COVID infection, especially severe COVID infection, have low platelet count. So make sure that there's no contraindication to providing regional anesthesia technique. The next one is the patient agreeable to having a procedure done in regional anesthesia technique? And that's a big factor. That's the absolute contraindication. If patient doesn't want regional anesthetic technique, we have to respect their wishes. The next is what drug to use and what dose to use. So using a short-acting spinal anesthetic and reducing the dose might not be the best strategy here. This is a time to discuss with our surgeon and surgical team as a whole as to what is the complexity of the surgery, how long will it take, and is this really doable under regional anesthetic technique, and dose accordingly. The last thing you want to do is halfway through the surgery trying to convert to a GA, which is less planned than what you would have in otherwise. And then there's no reason for not checking the block. Make sure the block is high enough to allow the surgery, is adequate enough to allow the surgery, and having a backup plan. Sometimes our plan one fails, and the backup plan can be as easy as putting an LMA in or intubating and making sure that we're prepared for that. So once we made that decision and we know about the surgical technique, let us talk about some of the analgesic options we have for hip fracture surgery. And I keep saying that to all my residents, is the best analgesia is getting the surgery done. Once their fracture is fixed, their analgesic requirements are so much lower. So get the surgery done as soon as possible in a safe manner. However, when it comes to regional anesthetic techniques, lumbar plexus block is probably the gold standard for hip surgery. But it's not a simple, straightforward block. It's a deep block. So not a lot of people are used to doing this block. The other options we have is femoral nerve block. However, most of the articular branches from the femoral nerve have already taken off to the hip joint when it gets to the femoral nerve here. So it's a good, reasonable block, I would say, but not a complete one. So, or there are should be better alternatives. One of the alternatives which has been suggested is a fascia iliaca block. And to my mind, I don't know, I'm not a big fan. I feel like fascia iliaca block is an inferior femoral nerve block, when especially with ultrasound, you can do those blocks, femoral block and LFCN block separately with lower volumes and more precisely. Why would you do or try to do a fascia iliaca block? However, there is also this suprainguinal variant of fascia iliaca block, Psi-5, which is fancy terminology here. And it's been described as looking for a classic bow tie sign there. I don't know, like when I scan my patients with the type of patients I get, I can't find any bow ties or even neckties there. But I've had good success with the recent PENG block. And this is one of the study which we just published, and it was mainly on elective hips, but we found that doing a PENG block reduced their opioid requirement by 2.4 milligrams of hydromorph. And hydromorph is very much North American drug. I had never used it before I came to North America. So I just want to clarify what that means. So 2.4 milligram of hydromorph would be something like 15 to 20 milligrams of parenteral morphine, if you convert it, which is fairly significant when you consider it's a hip surgery, and it's less so than knee surgery for sure, we know that. Right, so next few slides, I'll be showing you what I do for my PENG block. Generally speaking, what I do is I feel for the anterior superior iliac spine and use a curvilinear probe, just place it on top of the anterior superior iliac spine, and then start sliding the probe medially towards the pubic symphysis there. So what we see is something of this sort of picture, wherein we see the anterior superior iliac spine, and if we slide downwards, we'll see shortly is the anterior inferior iliac spine coming in the picture now. And then this white, shiny, roundish structure is in the picture now. So when I see that, and my residents are doing the block, then I tell them this is probably a bit too caudal here, because you can almost see the head of the femur here. This is the roundish head of the femur. So at this stage, what you have to do is move the probe a little cephalad until you find a picture which has a more straighter line rather than the femoral head picture. And you can see a little bit straighter line there, and that's your iliopubic eminence. In the same picture, you can see the anterior inferior iliac spine there and the femoral artery pulsating, and the nerve next to it, if you can see with the eye of a faith here. The aim here is to place the needle right over the bone, just underneath the pubic tubercle, which is shown here. Not pubic tubercle, it's a psoas tendon, which is shown here. And place the needle right underneath the psoas tendon and separate the psoas tendon from the iliopubic eminence by a local anesthetic. It gives a decent block if you separate and put local anesthetic underneath it. So this is not the first pandemic, and this is probably not going to be the last one. What we have to do is we have to learn what we can from this pandemic and use it for future pandemics. So this is a survey we did just to find out what people are doing. This was a joint American Society and European Society survey. I'm going to give you a little sneak peek into the results of the survey. What we were looking to see is, have people change their practice towards regional anesthesia or away from regional anesthesia during the pandemic? So this next slide shows you the use of neuraxial anesthesia. And I'm just presenting you the data of 3 countries, which is India, UK, and US. And they show quite different trends. So the first 2 columns show the use of regional anesthesia remained same or decreased. And the second 2 columns shows that the use of regional anesthesia, more specific neuraxial anesthesia, expanded. So in India, you can see that 50% people was kind of same and 50% expanded to include more regional anesthesia. In UK, actually, they expanded the role of neuraxial anesthesia for the surgery, whereas in US, it was on the lower trend, means that with pandemic, they were using less regional anesthesia. And there are various clinical and political factors around it, which we will be discussing when this paper comes out. So keep an eye on it, keep an eye for it when it comes out. I don't know. I think that's probably what I have to say at this point. I think we do have Dr. Bala put in an excellent COVID panel tomorrow. So there'll be ample opportunity to ask questions in that panel. But I'm happy to respond to any questions at this stage, or even better, if you want to discuss on Twitter, it can benefit the rest of the audience as well who are not in here. But yeah, I can take the questions, or we can leave the question after panel tomorrow, whatever you think. I'm sure there are a lot of questions on this hot topic.
Dr. Vishal, it has been a pleasure listening to you. Questions in the question box take a couple of minutes to come, but we have 1 or 2 questions for you right now. First is, what is the volume of drug you recommend using in pen block, and what are the drug additives which can be added?
Yeah, that's a good question. But just with most of the ultrasound techniques, I think a lot of it depends on your spread you're looking at. But in general, my approach is just still a new block, so we don't know the optimal dose. So I use between 20 to 30 cc's of local anesthetic, whichever usually ropivacaine.
Okay, and when it comes to getting the surgery done under spinal anesthesia, do you use isobaric bupivacaine, and what in countries which don't have isobaric bupivacaine and need to use epidural as a backup?
That's a very good question, and we've had this discussion in our block room for as long as I have worked. There are people who are in camps of isobaric, and there are people who are in camps of using hyperbaric. And when I started here, I was the only one who was using hyperbaric because it's a licensed indication. And in my hands, it produces a much faster onset block. But obviously, there are places to use isobaric bupivacaine as well. So we actually end up doing a systematic review comparing, because everyone was coming with different studies showing we should hyperbaric is higher failure, lower failure, all these arguments. What we find is with isobaric, isobaric gives you slightly longer duration of analgesia, about analgesia and anesthesia for about 30 minutes compared to hyperbaric. So if you have surgery, which is shorter in duration and more predictable, I would use hyperbaric. Otherwise, I would use isobaric, but because it does give you some extra duration of analgesia. But if your surgery is going to outlast spinal anesthesia, I suppose combined spinal epidural is probably the best option there.
Okay, and another interesting question is, should we hard sell regional to patients with COVID?
We are not selling anything to the patient, you know.
Yeah.
I know that's what it feels like, but I think it's about discussion of risks and benefits, you know. Until now, before COVID, we've only had discussion about risks to patient and benefit to the patients. I think this is a unique situation where we can add, I think we're justified in adding benefits to the healthcare team as well. Because ultimately, if we preserve healthcare team, that's going to be benefit for the whole society. If all our healthcare workers fall sick, have COVID, then ultimately who is going to be at the loss is going to be the patient itself. So it's not about selling, I would say. I would say it's about the discussion of risks and benefits, and also putting that this is possibly beneficial for your healthcare worker. And ultimate decision is theirs, you know, despite discussion of all these risks and benefits. If the patient strongly prefers a general anesthetic, PPE works. It's been shown in trauma again and again, you know. You wear PPE, it protects you, you know, but if we can avoid it, then why not do it? That's my argument.
So another question is, what is the best analgesic modality for post-operative pain relief in these patients?
Yeah, I think surgery is the best post-op modality. Get the surgery done, the analgesia goes down. To be honest, I'm not 100% even like sold on doing blocks for these patients, because any extra procedure you do for these patients, obviously it is beneficial for the patient. You don't want to be doing general anesthesia in patient who has respiratory infection from the patient perspective, and what you want to reduce the amount of opioids you're giving to patients who has a respiratory infection. But at the same time, you know, if the same analgesia can be achieved with multimodal analgesia, with some opioids, and if you can avoid an extra procedure, because every extra procedure you do does expose the patient, the healthcare team, to the extra risk of transmission of infection. So it's good to do these blocks, you know, if you can do it safely. But if not, I think the approach should be do the minimum, get the surgery done, and get out for these patients.
So Dr. Dr. Uppal, you have ended the fight between the surgeons and the anesthesiologists by saying get the surgery done. That is the best anesthesia you can get. So one last quick question which I'll ask you is, like, which has come up in the box is curvilinear probe mandatory for bank blocks even in thin patients?
Nothing is mandatory as long as you recognize the structures adequately. The population ideal, the reason I use curvilinear probe is it gives you a big view of everything in there. There's no reason you can't use a linear probe. But I would say is if you're using one type of probe, stick to it, because our eyes get used to the pattern recognition. So once you use this curvilinear and second time you use your linear probe, then your eyes are not used to seeing that image again, and you will have to put some extra effort in recognizing the structure. Having the curvilinear probe makes it easy because you can use it for bigger patients as well as smaller patients. Although I'm not a big fan of curvilinear probe, but I use the curvilinear probe for this particular block for sure. I
Thank
hope
you,
I've answered your question.
Yeah, I hope you will.
Dr. Jitendra, I just want to make a comment on the Dr. Uppal talked about some studies where they said that the patients who are operated in COVID times, they have higher mortality or morbidity. That's a very interesting thing, which way back in March when we were about to operate, we were trying to see whether we should do the elective surgeries or not. But at that time, these Chinese studies were quoted, and it's 6-7 months down the line. We are operating patients happen to come in emergency and who have COVID incidental or COVID lungs. I think the problem is not the anesthesia or the patient or anything. I think the problem is that once the patients are COVID, people are so afraid of doing the routine things. Either the surgeon will not do surgery, they will delay as much as possible, resulting into a problem. When they operate, they won't take care of the patients because they put them in the isolated environment where the standard procedures are never followed. And if patient has COVID lung, obviously that increases the mortality otherwise also. So I don't think COVID times as such, type of anesthesia or that anesthesia matters or not. But definitely, because the fear of COVID is one thing which is causing increased mortality among these patients. Okay. As far as the communication, aerosol generating procedures, fortunately for last 7 months, we have operated 250 patients. And when I see the type of anesthesia our residents and faculty give, though their aim is first to give regional, but whether because of non-availability of the best of the machines, whether because of non-availability of logistics, they end up giving general anesthesia. And till now, we have never got any person who has been infected with COVID from all these procedures, though it is only 250 procedures or maybe 1,500 patients admitted in various ICUs or wards COVID area. It's the proper precautions you take and the proper protective equipment, which does a lot of good things. And as far as mortality is concerned for the surgical patients, it's related to the fear of COVID and rather than anything else. Thank you.
That's great comment. I think getting a clean data in the situation is really hard. I'm sure that data is confounded by all these factors which Dr. Puri was mentioning. I just tell most of my colleagues who ask me this question again and again is like, if this, just forget about COVID, if this patient was having a pneumonia or was having any kind of respiratory infection, would you prefer a general anesthetic or would you prefer a spinal anesthetic? And then I don't have to ask any further questions again. But I totally agree. Doing any of these well is most important than one of these. Yeah.
Thank you, Dr. Brachial. It had been a pleasure talking to you, listening to you, and I'm sure you're going to stay with us as the day progresses. And we'll get back to you as and when we get more questions in the chat box, or we'll share the questions in your chat box as and when they come. So moving on, we all know that ultrasound has revolutionized the modern practice of regional anesthesia. If we can see it, we can block it. So while the overall number of regional anesthesia techniques described in the ultrasound era has increased, no subset has grown as rapidly as the interfacial plane blocks, be it truncal, be it thoracic. So today we are going to limit ourselves to thoracic interfacial plane blocks. We all know that there are controversies in the mechanism by which these blocks act, which block is like, whether it is the PEC block or it is the ESP, which is better. So there are still controversies regarding that. And we have with us Dr. Sondekoppam, who will tell us about the current evidence of efficacy of these blocks. So Dr. Sondekoppam is an alumnus from PGI Chandigarh and has brought laurels to the host today by his work in the field of regional anesthesia. He has numerous grants to his credit, through which he has been, and we are sure will continue to extensively contribute to the randomized controlled trials that are being conducted in the field. His areas of interest are basic science research in regional anesthesia and acute pain medicine. Welcome, Rakesh. We're over to you now.
Thank you, Dr. Makar. Hello, everybody. I'm really honored to be invited by my alma mater. I hope everybody can hear properly.
Yes.
Yes, we can.
Right. So thanks to the organizers and Aora for inviting me to this meeting. And I'm really, truly honored to share the stage with such eminent people as Dr. Apral and Dr. Karmakar. Like Vishal said, I've grown up in regional anesthesia, listening to and reading about the research from people. So it's so my topic today is interfacial plane blocks for mainly thoracic analgesia and what's the current state of evidence. I don't have any conflicts of interest. Like Dr. Makar said, I grew up in PGI. I learned all my basic skills in anesthesia from PGI, and I'm really thankful to all my teachers and mentors, especially Dr. Puri and Dr. Batra and Dr. Kajal Jain and Dr. Makar too. I worked with Vishal in London and then moved to Edmonton, but right now I'm in the beautiful Iowa City, which is kind of middle of nowhere, but it's a very beautiful town and a university town mainly. So today I'm going to mainly cover what's the intensity and duration of pain following thoracic surgery. I'm not going to cover more about a post-mastectomy pain because the evidence on that is fairly vast and the time constraint may not permit me to present all the evidence on it. We'll debate what is the gold standard, whether it's paravertebral block or thoracic epidural analgesia. I think Dr. Raval kind of touched on the topic and he got the gist out of it. I'll kind of make arguments for each as well. And we'll talk more about interfacial plane blocks. What are the proposed candidates? How do they compare against each other and against the gold standard? And also, what's the current level of evidence? Unfortunately, I won't be painting a rosy picture about the interfacial plane blocks. I'll tell it at the outset. And I share my sentiments about the interfacial plane blocks similar to what Dr. Karmakar has recently published in regional anesthesia and pain medicine. So pain following thoracic surgeries, it can be quite intense, especially thoracotomy. This was a study back in 1990, where the mean duration of pain was up to 7 days, and about 10% of patients reported pain lasting up to 21 days. So this was a study before the multimodal era became standard of practice. But recently, even in the VAT surgeries, it was found that pain intensity is not any lesser, although minimally invasive doesn't necessarily translate into minimal pain as well or less length of stay. So this was a 2020 study just being published in one of the thoracic journals, thoracic surgery journals, on 1,164 patients undergoing VAT study. Unfortunately, this is a retrospective study design, and they said that moderate to severe pain intensity was in there for 12 to 15% of patients within the first 48 hours of surgery. The consequence of this is very poorly controlled thoracic pain is one of the independent predictors for chronic post-thoracotomy pain syndrome. And 50% of the patients describe pain at 1 year, although the intensity of pain is very less. It's in a scale of 3 to 5 or in a scale of 0 to 100 sometimes. And it's also been shown that VATS is no better than open procedures in that 22 to 60% of patients do develop, end up getting chronic post-thoracotomy pain. There are various sources of pain in a thoracic surgery, mainly due to rib retraction, and that progresses over time. And it is one of the reasons why the pain transitions from side of the chest to the back, and so on and so forth. It's also due to intercostal nerve damage. Sometimes it's due to surgeons who put in pericostal sutures, although that is becoming rarer and rarer nowadays. It can be due to diaphragm irritations, which can be more problematic to treat, and it can result in shoulder tip pain. And this kind of pain is not amenable to either brachial plexus block or phrenic nerve blockade sometimes. And sometimes it can be due to diaphragm repair, which can result in phrenic referred pain. These patients also are asked to do robust chest physiotherapy and rehabilitation exercises, which can be sources of pain as well. And the duration of chest tube drainage is another predictor of pain and a predictor of chronic post-surgical pain too. So there are multiple sources of pain, of which intercostal nerve damage is the one strongest predictor for acute pain after thoracic surgeries. And that's why uniport versus multiport VAT surgeries have been explored for the pain perspective as well. So this is akin to a whack-a-mole where you're trying to cover multiple sources of pain, and trying to cover all of them is sometimes impossible. So nowadays we are going into the era of robotic surgeries, and one question we have to ask ourselves is robotic assistance any better? And this was again one just published article in one of the robotic surgery journals, which kind of, and they used epidural analgesia in open surgeries versus VATS versus robotic assistance. As you can see at the outset, the sample size is extremely low. And that's one of the causes of concern when we are interpreting any surgery journals, and many of this evidence from the interfacial plane blocks too. But this study didn't show any difference in the pain intensity or the duration of length of stay of the patients as well. Coming back to the big debate, which is the gold standard? Is it paravertebral or is it thoracic epidural? This was kind of answered in 2016 by Young and colleagues in Cochrane review, where they said that the VAS score at 24 hours and at rest and with physiotherapy or coughing was not much different between the paravertebral versus thoracic epidural analgesia. You had to consider the total number of patients included in the analysis. So it's at best weak to moderate level of evidence. But what they found was there was consistent evidence in favor of paravertebral blocks, in that the hemodynamic fluctuations were lesser. That is, hypotension not requiring vasopressors was fairly common in epidural and less frequent in paravertebral blocks. Other things which we have to think about is how often epidurals fail. Estimates range from anywhere between 28 to 50% of the epidurals fail in patients, and it depends on the definition of the failure as well. But when you look at head-to-head comparison, again, caveat is low number of patients to make any conclusive, any strong conclusions. But the paravertebral blocks have lesser failure rate. And also it has favorable impact on nausea and vomiting compared to thoracic epidural when done for thoracotomies. So paravertebral block and thoracic epidural, they are very well established modalities, and anatomical plausibility, we don't need to go into that. It has been used for decades together, excuse me. And we all know that they are better than systemic opioid-based analgesia alone. When you compare thoracic epidural to paravertebral, we just saw that paravertebrals have a better side effect profile than epidurals because epidurals can cause more hypotension. And since we are outside the neuraxis, there is less cause for concern, at least in well-experienced hands, when there are minor coagulation disturbances. But you would be cautious to offer epidurals even in the background of minor coagulation disturbances or stoppage of anticoagulants, not according to ASRA guidelines. The another advantage, I was listening to Dr. Karmakar speak in a pro-con debate in ASRA, and one of the things which really sold for me for the paravertebral block was that it could be performed by the surgeons in a very accurate manner. And he showed a very beautiful video of that too, which was super impressive. Both these techniques can have impact on chronic post-thoracotomy pain. There are some evidence to suggest that thoracic epidural, at least the mid-thoracic epidurals, are technically difficult to perform. There is upcoming evidence that impact on length of stay may not be better with epidurals. And at best, it's equivocal. And in fact, it may delay the length of stay in VAT surgeries with the use of epidural. So it makes sense when Dr. Raval and the Prospect group advocates paravertebral block as the choice of analgesia for thoracotomies, and to use thoracic epidural with the local anesthetic plus opioid based as the alternative. Paravertebral for VAT. So video-assisted thoracoscopic surgeries, there is no robust evidence as to which modality is better than which one. Most of the studies say that systemic multimodal analgesia is all that you need. And epidural is an overkill. That's the common consensus, and evidence-based too. But I will make a case that paravertebral block should be, again, the standard of care for even video-assisted thoracoscopic surgeries. Based on this small systematic review meta-analysis published in 2018, where the pain scores were fairly superior at 48 hours, and also at 24 hours, they didn't make much of a difference in the pain scores, but it had significant opioid sparing properties when measured and day of surgery and at 24 hours. So this makes a case again that we should be moving towards paravertebral blocks as standard of care for even video-assisted thoracoscopic surgeries. But having said that, regional anesthesia has exploded with numerous interfacial plane blocks because rather than anesthetizing specific nerves or nerve groups, we are in an era where, just deposit local anesthetic in between the myofascial plane and let the local anesthetic reach its target rather than directly injecting around the nerves. That has been popular since the tab blocks in 2001 and onwards. And so we tend to deposit local anesthetic between the myofascial layers. And it is a good wishful thinking that it's an additional option to provide anesthesia and analgesia when you cannot perform thoracic epidural, or your thoracic epidural fails and patient is in pain, or you cannot perform paravertebral blocks due to lack of skill or lack of resources. So it's good to have additional options, but we also want to ensure how well they perform before we offer it in a consistent manner. So what are the candidate alternative thoracic interfacial plane blocks? Very popular one is the PEX block, more so the PEX2 block. Then the serratus plane block, which is a modification of the PEX2 block by the same investigators. More popular nowadays is the erector spinae plane block. And there are a plethora of blocks like transversus thoracis plane block, rhomboidus intercostalis subserratus plane block, retrolaminar blocks, midpoint transverse process to pleura block, costotransverse block, so on and so forth. And every other day there is a new block being born. To capture the anatomy, retrolaminar blocks are performed closer to the lamina, just medial to transverse process underneath the erector spinae plane and erector spinae muscle. And the idea and hope and wish that the local anesthetic deposited posterior to lamina somehow magically goes into the paravertebral space through the costotransverse foramen. And a similar idea with the erector spinae plane block too. And the other ones are serratus plane block, either where it's performed between the serratus anterior muscle and latissimus dorsi in the lateral border of pectoralis minor. There are two approaches to it, either deposit deeper to the serratus muscle and superficial to the serratus muscle. And the PEX1 is between pectoralis major and minor, and the transversus thoracis is between the internal intercostal muscle and the transversus thoracis plane itself. So I briefly explained the transversus thoracis. So this is the internal transversus thoracis muscle and the internal intercostal muscle, local anesthetic being deposited there. PEX1 and PEX2 PEX1 is between pectoralis major and pectoralis minor muscle. But if you go to the lateral border of pectoralis minor here, the pectoralis minor being visible here, and on top of serratus anterior muscle, that's PEC2 with the probe slightly laterally positioned compared to the PEX1 block. And then the serratus plane block is at the level of fourth rib. You visualize the fourth rib and the serratus anterior muscle on top of it. And between the latissimus dorsi and serratus anterior, you deposit local anesthetic. Typically 20 to 30 mils, although higher volumes are better for serratus plane block. And erector spinae plane block, you visualize the transverse process and the erector spinae muscle and try to open up that space with coming in plane and try to deposit your local anesthetic between the transverse process and the erector spinae group of muscles. So this is akin to telling spray and pray. So let us put a lot of local anesthetic in some interfacial plane and pray to God that it reaches that nerves of interest, basically. So my, at least my philosophy is that to follow what has been the traditional route of evidence generation, phase 1 trials always looked at pharmacokinetics. Phase 2 trials in any new drug. So before all the phase 1 and phase 2 came in, we had to do in vitro testing or preclinical trials, which was followed by clinical trials. So phase 1 is pharmacokinetics. Is it safe for the patient? And does it actually work in patient is phase 2? Does it work double blind in comparison to the gold standard? And are there any further benefits from it? And is there any data coming back? Say when we pool all the data in clinical trials, is there any adverse event or is there any added advantages when you're continually monitoring drug metabolism or in this sense, looking for the safety and efficacy? So present to you interesting hypothesis. Can we consider preclinical trials, which are mainly plausibility studies in pharma trials? We can consider the cadaveric studies to be preclinical trials in regional anesthesia. Phase 1 trials mainly look at plausibility in humans, and akin to that is volunteer studies where we look for dermatomal anesthesia in volunteer studies. Phase 2 in pharma trial usually looks at the dose response, or does it actually help these patients? And that kind of an evidence comes from case reports and case series. Phase 3 is efficacy and safety compared to the gold standard. And usually single center RCTs are the way to begin that kind of a exploration, but they are unfortunately, they predict large effects and also are littered with type 2 errors commonly. So it has to be replicated by other investigators and has to be reconfirmed by replicative studies in most, ideally in a multicentric RCTs, although there are alternative study designs like database trials and etc. Then the post-marketing data is like pooled evidence. So it's from the form of systematic review meta-analysis. And we have to continually evaluate impact of regional anesthesia on length of stay, discharge opioids, chronic pain, or other cardiovascular profiles. In the case of thoracotomy is incidence of atrial arrhythmias. So to establish that as a standard of care, we need multiple randomized controlled trials to go in the same direction of effect, or at least a multicentric randomized controlled trial which is well conducted. At least this is my school of thought. So we can rate these next few blocks based on the anatomical or clinical plausibility. If there is any cadaveric or volunteer studies which go in the same direction, can it be considered standard of care? Is there more than one study which goes in the same direction of effect? Or is there a systematic review meta-analysis of pooled studies which kind of show that these blocks are beneficial? Does it impact chronic pain? We can give 1 star because that's a huge thing in thoracic surgeries. Are there any significant non-analgesic benefit like length of stay, discharge opioid, cost economics? And is it technically very easy to perform, which is one of the biggest selling points for interfacial plane blocks? We'll briefly talk about pectoralis 1 and 2 blocks. These cadaveric studies, PEX1 limited the spread only between the pectoralis major and minor and covered mainly lateral and medial pectoral nerves. We know that. So the candidate block among the PEX block for thoracic surgery is PEX2 block. Unfortunately, it mainly stains the intercostal brachial nerve, third intercostal nerve, thoracodorsal, long thoracic nerve, medial and lateral pectoral nerves. All these nerves, as you can read, are not intercostal nerves except the intercostal brachial nerve and probably third intercostal nerve. So you get a partial thoracic cover, thoracic dermatomal cover with PEX2 block. And hence, it may not be very suitable for thoracotomy or VAT surgery. And it has not been well studied in thoracic surgery, although in breast surgeries, in placebo control, they have consistently shown better pain scores at early and at 24 hours compared to placebo. Paravertebral PEX block has been also PEX2 block has been comparable to paravertebral block both in mastectomy and non-mastectomy surgeries. So yeah, PEX2 is good for breast surgeries and it can be almost as comparable to paravertebral block for breast surgeries. But for thoracic surgeries, hardly there are any randomized controlled trials. There's only one cardiac surgery trial. It's a single center RCT, which was comparison between single shot PEX2 block versus control. And there was some analgesic benefit when performed for cardiac surgeries, but you had to perform bilaterally. And they saw all the analgesic benefit lasted up to 18 hours post-op, but nothing beyond that. Serratus plane block is a much more promising block. This was originally described by the same authors, Blanco and colleagues, who described the PEX block. And they kind of make a bold prediction that injection of local anesthetic superficial or deep to serratus anterior provides predictable and relatively long-lasting regional anesthesia. And they kind of map the dermatomal anesthesia when it's superficial to the serratus plane, the local anesthetic being deposited, and it's a wide dermatomal spread. And deeper was slightly restricted. This was reconfirmed in a different study with by Dr. Chan and colleagues from Toronto, which kind of said that when you're superficial to serratus plane, there's a limited spread, but when you're deeper to serratus plane, or when you do double injection, the spread is much wider. And they kind of recommended at least 40 ml of local anesthetic divided between the two levels to consistently reach both the anterior chest wall and also into the axilla and cause much wider analgesic spread. Serratus plane for thoracic surgeries has shown to be better than no block or a placebo mostly for the VAT surgeries, as you can see. And again, very low quality of evidence, just 3 trials on VAT surgery so far. There are a couple more in the recent past, and we'll touch on that. In thoracotomy, although the ethics of performing control or a lack of a gold standard in these 2 trials is questionable, the serratus plane block didn't show any better analgesia than control for thoracotomy surgeries, mainly because the intensity of pain is much higher with thoracotomies. Opioids and post-op nausea vomiting was in favor of video-assisted thoracoscopic surgery, although with the limited amount of evidence we have, again, the serratus plane block may be much beneficial for VAT surgeries. There are a couple more trials since that meta-analysis was published, which was comparing systemic analgesia with the serratus plane block, and it goes along the lines of the systematic review meta-analysis. There's been only one study wherein the serratus plane block is being evaluated against the thoracic epidural analgesia, which is the goal, which can be the considered gold standard in this case. And they showed a VAS course and morphine consumption were equivalent in the 2 groups, but the study was confined to the first 24 hours post-operatively and had a very low sample size of 20 patients per group. And this didn't employ thoracic epidurals using combination of local anesthetic and opiate. Erectrospinea plane block, the most popular kid in the block on the, well, the kid in the block to say plausibility studies. Again, the plausibility studies with ESP are again inconsistent. The initial studies were conducted in volunteers, which showed wide dermatome anesthesia. Unfortunately, the cadaveric studies by Michael Barrington and other colleagues couldn't confirm the same kind of paravertebral spread with erectospinae plane blocks. Although the studies by Dr. Adhikari and Dr. Jinchin, again, were showing consistent paravertebral space. So at best, we don't know what the true mechanism of analgesia with the erectospinae plane block is. And I think the local anesthetic usually spreads along the path of least resistance, and it may reach paravertebral space, but it's not a consistent spread to paravertebral space. And that can determine the efficacy of analgesia too. What cadaveric models do not evaluate is non-regional, loco-regional mechanism of analgesia. And there can be quite significant systemic absorption, which can cause analgesia in these interfacial plane blocks too. For thoracic surgeries, there are hardly any clinical trials, and more so in comparison to paravertebral or thoracic epidural analgesia. There's only one randomized controlled trial for post-mini thoracotomy cardiac surgery, where it did show a benefit at 24 hours and 48 hours compared to intercostal nerve block. And there was also a significant opioid sparing effect at 48 hours. But for video-assisted thoracoscopic surgery, there's one trial which is just being published last year, at the end of last year. It showed that over a span of 48 hours, VAS at rest was much better with paravertebral block consistently. This is the white is a paravertebral block, and it was almost always lower compared to erectospinae plane block or intercostal block. And the effect remained the same even on movement. And the rescue analgesic requirement was actually higher in the erectospinae plane block compared to the intercostal block. Therapeutic levels of plasma lidocaine is a well-known entity, and this has been like the therapeutic levels needed to achieve the analgesia is well known. It's somewhere between 2 to 5 micrograms per ml. And this was established way back in 1991, and multiple studies and systematic reviews have confirmed that plasma level of local anesthetic rises after any brachial plexus, any interfacial plane block or peripheral blocks, and that can have some significant supra or systemic analgesic effect. And on the similar lines, there was just a retrospective cohort study published in RAPM last issue, which says that IV lidocaine, systemic administration of lidocaine, was as good as epidural for patients with multiple level rib fractures. And it had a significant opioid sparing effect too. Chronic pain is poorly studied. The impact of regional anesthesia in chronic pain is poorly studied. The most of the evidence comes from epidural analgesia. For every study back since the 90s, which are in favor of epidural in preventing post-thoracotomy pain, there's one which says that it is not so. And there have been a couple more trials since then, which kind of go back and forth on the evidence. When it comes to length of stay, there's one thing certain, that epidural analgesia usage has actually delayed the length of stay in video-assisted thoracoscopic surgeries. And lack of epidural analgesia does not increase the morbidity or their recovery profile. So going by all the evidence we pulled so far, if we had to assign a star, so the plausibility is very good for thoracic epidural and paravertebral blocks. Can we use it as a standard of care based on multiple randomized control trials or systematic review meta-analysis? Yes, for thoracic epidural and paravertebral blocks. Does it impact chronic post-thoracotomy pain? Equivocal for thoracic epidural. Most of the studies do not have any evidence. Non-analgesic outcomes like length of stay and home opioid. Length of stay may be slightly in favor of paravertebral block. And also the recovery profile, the nausea, vomiting was slightly better with paravertebral block compared to epidural or thoracotomy. So had to give a half a star there because of that. And it's slightly easier to perform than a paravertebral block. So not giving the full star, although all the interfacial plane blocks we can give, it's easy to perform. That's why they're popular. PEX block, there is a plausibility, but there's no very good amount of evidence for analgesic or non-analgesic benefits. Serratus plane block, there is a good amount of evidence to be a standard of care for video-assisted thoracoscopic surgeries, but much better evidence is needed for thoracotomy. Erectus plane block, unfortunately, suffers from even plausibility study reconfirmations, although it's very easy to perform. There are other candidate blocks which have plausibilities, but need better evidence at present. In summary, Dr. Sui, who's one of my mentors in regional anesthesia too, we both published this editorial recently with the expanding interfacial plane block arena. We have to take a pause and take a back step and see, okay, before I offer it to my patients, what's the level of evidence? And we cannot offer these blocks just based on case reports or case series. And single center RCTs are just hypothesis generating. They are saying that there may be an effect there. You need replicative studies before you start offering them as standard of care. And multicentric RCTs are ideal, but they are hard to come by. They are time and cost expensive. So non-randomized trials with good study designs are probably the better way to go in the future. And also, apart from analgesic efficacy, each and every institution has to consider what works for their organization. Is it cost economical for them? Is it easier for them to perform and consistently offer? Because the last thing you want to do is offer some complex modality, which only you can do it, but nobody else can offer it. And it's something very hard to do it. And the ease of performance is the main reason interfacial plane blocks have exploded into field. And that's one of the big selling points too. And you also have to have a outlook for non-analgesic outcomes like safety profile, complication rates, or like length of stay, discharge opioid, and etc. And chronic pain, most of them. So to summarize, paravertebral block is still the analgesic technique of choice for both thoracotomy and video-assisted surgeries. Serratus plane block needs better evidence in thoracotomy, but there is good evidence to say that it can benefit in VAT surgeries for now. ESP, unfortunately, is not an ideal block to be offered for thoracotomies or video-assisted thoracoscopic surgeries unless more evidence on the topic comes in favor of it. Right now, it performs inferior to paravertebral block and also serratus plane block for breast surgeries too. Newer blocks need to be evaluated, and we have to resist that urge to implement newer techniques. And definitely, even for paravertebral and epidural analgesia, more evidence is needed for their non-analgesic benefits. Thank you.
Thank you, Rakesh, for an elaborate talk. And I will also like to take this opportunity to thank you for being our resource person for this webinar. We have a couple of questions. I'm going to ask you one or two only, and then we'll move ahead. And I hope you will be with us in the end of the session to answer the rest of the questions. So the first question is, which has come up, is that seeing the risk-benefit ratio, if you see there is an incidence of complications reported with paravertebral blocks. So is there any evidence on what is the risk-benefit ratio? Like if we see the risks associated, what is the incidence of risks associated with paravertebral blocks? And is there any risk-benefit ratio related to complications when we say like
They're better than
that these blocks, that the interfacial plane blocks are better than paravertebral blocks?
Yes, so definitely the risks are lesser with the interfacial plane blocks because they are not going near any vital structures like pleura or nerve, uh, and they are relatively avascular planes where they are performing it, compared to a paravertebral block where you can have a pleural puncture, pneumothorax. Local anesthetic systemic toxicity is a real concern with paravertebral blocks, especially with prolonged infusions in elderly population or when we perform it bilaterally. And Dr. Karmakar's study showed that when you perform it for bilateral surgeries in cardiac surgery patients, you can easily go above the toxic threshold. And even our study reconfirmed it in abdominal surgeries. So there is a real risk for local anesthetic system. And paravertebral block is one block which has the highest risk compared to any other block because it can cause epidural spread, intrathecal spread, it can cause pleural puncture, pneumothorax. And bleeding complications can be very sinister because it's a continuous space and can accommodate a lot of volume. But the saving grace in thoracic surgery is that most of these patients do get chest tube and they do get opened up and they do get treated for the worst complications with paravertebral blocks. So in that sense, we have to take that bold step and improve our skill set so that we can offer paravertebral block in a safe manner. They are deep blocks for sure. And the ASRA guidelines state that they have to be treated like in neuraxial block. But the caveat is that you can ask your surgeons at the end of surgery to do those blocks for you.
Yeah, definitely. And another quick question is that in multiple rib fractures, which is the preferred interfacial plane block? And is there any difference between interior and posterior approaches for the same?
So yeah, for multiple rib fractures, if we have to choose an interfacial plane block of choice, with barring paravertebrals or barring epidural analgesia, then I think serratus plane block has shown great promise. Although I tend to do all the local anesthetic injection above the serratus and between the latissimus dorsi and the serratus. Some people, if they're doing single injection block, they do deposit half the volume beneath the serratus and half above the serratus plane as well. And that was the study by Dr. Chan et al., Chan and colleagues, which showed that the double injection, especially half below and half above the serratus plane, resulted in better spread in cadavers at least.
So we are going to let you go at this moment just to ensure that Dr. Bansuri doesn't have to wait for a longer period, but we are sure you're going to stay with us and we will get back to you in case we have more questions in the next 1 or 2 hours. So regional anesthesia has an established role in providing perioperative analgesia for shoulder surgery. However, we know that the phrenic nerve palsy is a significant complication that potentially limits the use of regional anesthesia, particularly in high-risk patients. So to enlighten on the strategies to reduce the complication, we have with us Dr. Ban Sui from Stanford University. Dr. Sui is a clinician and a researcher who aims to transform regional anesthesia from an art into a reliable and reproducible science. With numerous publications and research grants to his credit, Dr. Sui has a strong interest in mentoring and motivating residents and anesthesia fellows for research in regional anesthesia. So ladies and gentlemen, presenting to you Dr. Ban Sui.
Thank you. Thank you. It's a great honor to be invited here. So I'm going to share my screen. Everyone, for me, it's a really early morning. So we'll see. Okay. So yes, once again, thank you for inviting me here. So it's an interesting topic that I've been working around this topic for a while, from trying to do different block and also try to rescue what we're talking about, the major problem. So we're going to, in this talk, I'm going to go back a little bit, talking about different approach, and then look at how the people are thinking about the old and new. Now, before disclosure, nothing involved this talk. So as I mentioned, that I'm going to talk to you about in terms of outline of the regional, say, as we know, the standard of care, most places do interscaling block, but we have other alternative approach, neither old or new, because as mentioned that the phrenic nerve palsy is still a major problem. And also that kind of complication or so-called side effect from interscaling, or if you look at the alternative approach, do they also have the same problem too? Now, like all regional anesthesia, we have to understand the anatomy and also select a different approach for individual patients. Some patients high risk, then we should choose a more conservative way, or people that can tolerate it, then we should using the most effective way. So we basically have to balance the risk and benefit. Now, if you look at this 3D model, basically this is the shoulder we want to try to block, but obviously they have many different ways to do things before, like from really peripheral, further away from the spine, and then get closer and closer to interscaling, and then you can say epidural, or we go on from the back too, from the latest ESP block. So we will try to look at each one. Obviously, as I mentioned, that now most people using interscaling block because it's for its effectiveness, but we always on the literature talking about compare different block, compare this more peripheral one or a supraclavicular. What we're trying to do is trying to avoid potential problem. What we're talking about is the phrenic nerve. Because you can see if you do interscaling, it's not far away, just a thin anterior scaling muscle separate from a small distance from the phrenic nerve. And the phrenic nerves basically control the diaphragm. It do have some clinical significance for a certain population. So why don't we look at each one, what we're talking about, what block we're talking at. The first one, we're looking at this one. Now this one actually described a while ago by Darcy Price from in New Zealand, unfortunately passed away. But anyway, when he described this one, you can imagine basically two blocks. One is a suprascapular block, and then one in the axillary. But you can imagine for this block, basically more amended to more single shot because it will be too close to a surgical site, particularly if you're doing a total shoulder replacement. So it's not that practical. But for long-term pain control. But obviously, what's the most attention is people will try different way to do things like how to attack the brachial plexus. Now, instead of go each one, basically they have studies showing many times that compare all the different kind. But the simple thing is when you get further away, we're not as strong in terms of pain control compared to interscaling. It makes sense in a way that because it's the local anesthetic and just like a spinal always stronger than epidural, peripheral, etc. But where we strike the balance, like this one, this diagram was to show you that in certain cases, if you're further away from the phrenic nerve, from interscaling to further away, then you have a less chance of phrenic nerve palsy. That makes sense. But you're paying a price somehow that you basically lose their effectiveness. So where we're going to draw the line to say we would take the less effective for less complication. So this is quite dependent on the patient. Now, we just move on, turn back the time in a way that cervical epidural. I know probably many people say, what are we talking about? But actually, I can tell you that in 2000 or some prior to ultrasound, at the time, to be honest, at that time, don't believe the peripheral nerve block can be successful. At that time, is here means only a few skilled person can do it. The rest is majority of the time you say depend on the patient, depend on the luck. That may work, like even interscaling with nerve stimulation, and also have a lot of complication. At that time, I focus more on the neoaxial because I find it's more reliable. But obviously, it's more invasive. So first thing at that time, when I just become a consultant, we do some different study. Basically, this one is first done is at that time developed the stimulation test. Basically, you can guide the catheter for whatever level. At that time, we do a lot of thoracic epidural. Just like we're talking about now, they're actually doing less and less because of the interfacial brain brow pervertebral. But at that time, thoracic epidural is quite common that we do in our institution. So I take one step further, say, can I guide the catheter to the cervical region that I can using extremely low amount of local anesthetic and achieve the effect. So basically I thread it up to the cervical region. Basically I'm using like 2 cc time. It worked. At that time, I'm calling this kind of block is like almost like waving a epidural. You know, at that time we're talking about walking a epidural for a lady having a baby. So with this, actually move on to do this. Actually, we have great support from the surgeon because they say the patient do well, have no trouble breathing, no pain, and you know what the surgeon always want. Your catheter is far away from what I'm doing, so that's great. I don't like your tape getting too close to our surgical site. Now, just show you a really old clip. You can see when I look back, it looks like I'm much older now, right? So basically get the thoracic region, inflate the catheter, and then we connect that to a nerve stimulator. Now people commonly ask, well, that hurt? Actually, it's not hurt at all because when you're using it, it's almost like how we do nerve stimulation for intraskating when we get the nerve stimulation. So you basically can position what level you want. Now, obviously, then people say it's too invasive. It's true in a way, do have a risk associated with it. Now with ultrasound, so it's less reason to do it. But now people go to the other side. Okay, everyone always say that ESP is almost like poor man epidural. So we'll look at how it's going to work. Now, as we discussed that, interfacial block is basically, we don't know where we put our stuff. We just put somewhere in between the muscle and hopefully can do something about it. So in other words, the minimum requirements, you need a right spread. So in other words, you need some kind of large volume. Depending on how much your pressure and flow, it do make a difference in terms of its success rate. So in other words, most ESP block, probably you need some kind of low pressure system that you can inject to it and your pump have to doing better. Now, I think that's why maybe a lot of people report single shot seems to work well for the first 2 hours, but the catheter itself doesn't work that well because most pump can only generate so much pressure and also the pressure head is not enough. That may be reason. Now, don't want to go detail of it. I'm sure that other talk would talk about that more. Basically, you try to inject something underneath the muscle, ESP muscle, you're trying to maybe leaking somewhere, hopefully, to get to your target. Now, if you do that, so next thing is we do brachial plexus, put the a needle here, inject some local here, and but at the same time, we worry about the phrenic nerve in front of it. But what about just using the concept of the ESP? How about we inject behind the transfer process? Would that work? Because eventually it may lead to that way, right? So, and actually report that actually it can work in this situation, like single shot, it still work well. Basically in this ultrasound, basically you can see almost like posterior approach. In the old day, what we call the posterior approach to pervertebral block almost, but except is more like behind the transfer process instead of in between. So we move that forward to see, okay, do a cadaver, can we actually see how it's spread if we directly inject into this area? What is the mechanism why the patient seems to do better? This is a dissection, but I don't want to bother you with your detailed thing. But basically, this is brachial plexus. When we inject it, we do see some dye leaking into that area. Of course, this is a cadaver study, but you can see the majority will be, in other words, it may explain why it worked. And usually it's, the phalanx nerve is sparing because you basically have an extra muscle the thigh have to go through. Now, just like how I do cervical epidural, and a lot of our colleagues might say not comfortable to do cervical epidural or cervical anything. So next thing, straightforward question is, can we actually flow the catheter up? Because if you look at this one, majority we're talking about T1, T2 level. So we don't have to go to cervical region. If you thread it somewhere in the T1, T2 level, it may leak anterior to the brachial plexus, almost like equivalent to supraclavicular block level. So actually this triggered me to do the first one doing that, because in this case, maybe just quickly go for it, is for a quarter, the patient is so much pain. They book for amputation the entire arm and so forth. And actually the patient actually come to the surgeon is not trying to cure the problem from the sarcoma. It's basically so much pain. They say, oh, why don't you just take it off? And the surgeon saying, okay, we can actually potentially help your pain and remove this sarcoma, but you are in cardiac, you're elderly, potentially you may die from it too, but that eventually, either way, you actually achieve what you want, your end of life option. So when they go on, obviously for anesthesiologists, what we're going to do? Not much space to put it. So do we use scaling? Or can we do cervical erectile spinal block? But actually then at that time, because there's not much room, it's hard to secure the catheter. So I do it from the thoracic region. And this is the next day, the patient basically have no pain. And this is surgeon say, and this is what prior to surgery, afterward, the patient family immediately asks for withdraw all the so-called DNR, so they don't want to die anymore because the patient is feeling well. This is the next morning, having a breakfast. We're talking about like almost 6 hours after the major operation. With this, we basically talk to the surgeons and maybe we have something that we can work on, like everyone else trying to do their try out all the interfacial brain block, may be alternative, because in theory, based on cadaver study, that we may even potentially remove any potential risk of phalanx nerve palsy from the block compared to interscaling. So we did the study with my fellow, and actually this year, unfortunately, the answer canceled, but they still presented. They get the best meeting award, but don't want to bother you too much on the detail. Basically, we look at ESP, high ESP, we thread it from T4 level and if high the catheter up. Basically, the result is with the high thoracic ESP, none of them have any phalanx nerve involvement, but the interscaling basically have 65% have full palsy and then have partial for the rest. The definition of that is all patient, both group, we do the post-op and pre-op ultrasound of the diaphragm to see the movement. Now, obviously, just like what we talk about, you want strong anesthesia, you usually associate with some phalanx nerve palsy. In this case, we try to pull the catheter further on the back away from the brachial plexus to avoid the risk to get to the phalanx nerve. Obviously, if you look at the pain score, the initial postoperatively, the ESP is worse than the interscaling, but it's quickly that will be more or less equivalent. Now, that may be one of the reasons why is the study design, because in ESP, we mentioned that we need large volume, but in this case, we're using the same dose for interscaling and the ESP initially in the post-op period. So that's why I would say under dose of ESP, but at the same time, I cannot give 30 cc or 20 cc to the interscaling. That becomes unsafe. So, so we have to live with that for the study design. at the end of the day, if you look at D-Chan study, it's basically, summarize what I say, it's basically most of the time when you have low incidence, then usually you may have questionable analgesia. Even those, when we look at all the proper ESP on the cervical or high thoracic, yes, we do have a small amount, like 15, 16 patients seems to be no diaphragm, but at the same time, I strongly suspect that the pain control is not as strong as interscaling block. So we're talking about, we're trying to move the catheter out, back and forth, try to avoid the phrenic nerve, using different effort to do it. And then at the same time, plate prices become less effective. So next thing is, can we actually target the phrenic nerve? What about if we can do something about the phrenic nerve? Obviously, why we so worried about the phrenic nerve palsy? Because when they have it for COPD or pulmonary compromised patient, you need oxygen, you may need to rescue intubation. But the question is, can we do something about it? One thing actually that a while ago, that actually can we reverse local anesthetic? So what happens is in the case that the patient almost an imminent problem, that we actually inject local, using the same catheter, give a normal saline, and then immediately they get better in terms of reverse the local anesthetic effect from the phrenic nerve palsy. This kind of experience, not only myself, like people report a case report here and there from different places. This one actually, what they do, they don't have a catheter, they just give another single shot with saline and also can rescue it. And after that, actually, like Virginia Mason and other places, actually they build in a protocol. If the patient is severe pulmonary compromise, they first will be, while they get the airway support, they will inject saline to try to rescue that. So same thing, we have a similar case at the Stanford. So they have problem after with a lung cripple and problem. So we give saline and we bet much better. So this one just show you, we also have the video to show that this is before, is demonstrate that it's actually nothing moving at all. But after the 5 minutes after the saline, you can see lung sliding and fickling on the diaphragm. So it actually reassured that it actually working. So obviously we want to do a proper study again. So this one is the second fellow that worked with me, and also she get the second award for the Astra too. Basically, we look at what if we give 10 cc every 10 minutes, can we reverse the localness, the phrenic nerve palsy? The study design is relatively straightforward. Basically, they post up, everyone get a set those same amount of local anesthetic to reset, make sure everyone block it at the same time so that not affected by the how long the surgery, how much blockade, to all block it and then measure the diaphragm. So what you find is basically before the washout, 60% will have a full diaphragmatic paralysis, just like the other finding we have, in a way that with the compared with the interscaling with the ESP. And the two group, one group with the saline was within that 10 cc every 5-10 minutes. You can see the other group actually much lower incident and prevent become a full hemodynamic paralysis. Now this basically will show you that on the control group, more will become fully paralyzed, but the other one is basically stay more or less the same, and this will go into publish soon. But one question I always ask, what about the brachial plexus? Do we actually reverse it? But the answer is no, it doesn't affect it at all. And actually we have another study we're going to show you in a minute, but basically the question is, why the mechanism. Is it dilutional, pH, or sodium low, placebo, or actually reverse the block? Now, as I mentioned, that people will ask why you can reverse panic but not affecting brachial plexus. We do a study with one of my former fellow in New Zealand. Basically, this study, we do it on the sciatic nerve using same washing regime. Actually, like after the block, we wash it for an hour and so, but you can see there's nothing changed on the peripheral nerve. The hypothesis I have is because phalanx nerves is relatively small, and because the phalanx nerves is only the nerve that are getting firing every 10 to 20 minutes trying to breathe, so only so-called the frequency-dependent nerve that actually the brain trying to trigger. So that may help to open up the channel when you have a favorable non-local anesthetic media. That's all hypothesis, but clearly, I think the size of the nerve, etc., and the brachial plexus and the sciatic nerve will play a part. But finally, I want to say we so focus on the phalanx nerve, but actually when we do shoulder, one thing we have to care for is because the shoulder also most places still on the so-called the sitting position. And with this sitting position, you can see sitting up may get you most commonly what drugs we use after induction. Particularly, we have a good interscaling block. Is we need a lot of pressure, like phenylephrine, ephedrine, epinephrine, etc. So which drug we should using for better one? But actually, there's one of the study I'm going to is currently trying to do it. We're going to try to do cerebral transcranial Doppler to see the blood flow, etc. What actually vasopressor will be better for those kind of situation. But we all know that when they're sitting up, this is a risk. One of the common thing that I think most of us will experience that they got hypotension and sometimes bradycardia when they after intubation sitting up, and then we have to grab our pressure quite often. So I think this is another area that we should look at, not just look at the phalanx nerve palsy. Intra-op management still a major problem, may lead to major problem. You can imagine when you have the good block working, they don't have sympathetic from the surgical stimulation. Soon enough, they may drop the blood pressure. So in summary, I think this is fairly accurate. More close to the practice, probably more effective, but more phalanx nerve compromised. Cervical epidural is really effective, but it's more invasive. And if some complication come up, will be quite severe too. Now, the ESP, I think most of us know that may work, don't know, but may be reasonable alternative for high-risk patient because better than doing nothing, but it's much less effective for interscaling. So in other words, I won't recommend that not doing any interscaling for even for 40 years old healthy person. Probably interscaling would be better for the pain control rather than try the ESP. Now, another thing we should look at, how about if we do interscaling, but we build in some kind of preventive measure, maybe saline wash before every bolus, but it may be complicated. But anyway, that may be an option that we should keep in mind that it may be useful. So finally, I think there's a need, a lot of research to talk about is the hemodynamic instability when they're on sitting position, particular combination of regional anesthesia. I'm not sure is the regional is the covert or the sitting position, because in theory, you just blocking one arm. It shouldn't have too much sympathetic blockade will causing hypotension, but this is what we're observing. So with that, thank you very much. It's my pleasure to be here. Thank you.
Thank you very much, Dr. Sui, for appraising our attendees. The new blocks for total shoulder arthroplasty, particularly interesting was the concept of high cervical erectospinal block and reversing the phrenic nerve palsy using normal saline. And I will also like to add that we had been looking forward to have you with us for Aora 2020 in person. Unfortunately, you had some commitments at that time. So this COVID pandemic has given us an opportunity to hear you on this virtual platform. So one good thing about COVID-19. So we have a couple of questions for you here. The first one is, how do you control the movement of your catheter tip to reach T1, T2 level in high ESP block, as the catheter may get folded between muscle layers?
Okay, what we're using is the standard Teraflex catheter by itself, also the stylet there. So you can usually stabilize it. What I find is that for ESP to be working, when you thread the catheter, even we're talking about go to cervical or not, you shouldn't have any resistance. When you have resistance, that means you curl in the muscle. Another way we've been doing it is we actually find it quite useful, but as a confidence, I don't use the using catheter over needle, because those catheter is more stiffer, so we stay in the plane. So we find actually we switch over a lot for our cardiac surgery, because we find it stay in the plane rather than in the muscle. Because if you're using the soft muscle, soft catheter, it can curl up in the muscle. It's true if you don't have a stylet. So you have to using stylet to thread it up.
Okay, and another one is, out of selective trunk block involving interscalene approach of brachial plexus and cervical erectospinae, which one would you think would be easier to learn for people in initial years of their practice?
I would say the interscalene, because more clinicians know how to do it. We have like almost 40 years experience on it. With the ultrasound, majority of the interscalene block will be easier, because you can supine, doing supine. But when you're trying to do direct cervical ESP, you have to be from the posterior approach with the head down position. So it's a bit awkward for most people, and potentially what I find is a lot of ESP, if you do it, when you give a big bolus, sometimes they get vagal and get hypotension too. So to answer your question, I think the interscalene will be more, should learn first, should use it more common, just reserve those ESP for high-risk patients that cannot tolerate interscalene. And a lot of time in the old day, I would do a like supraclavicular block. Most people know how to do it, will be safer and quicker as a single shot. Catheter doesn't work that well because there's no muscle to hold on to it, unless you even lower using Dr. Kamaka method to do almost a subcostal approach pointing upward. But anyway, so interscalene will be the first choice.
Okay, and another one is that for cervical epidural for upper limb surgery, like for shoulder surgery, does the local anesthetic, is there any way by which local anesthetic can be trickled to one side, or will the patient have blockade of both upper limbs? Can a differential one-sided cervical epidural be done?
Technically, you can steer the catheter on one side, but that takes skill in a way that in the old day when I'm doing it, when I want the catheter to go on the left side, I will do my thoracic approach from the right side, pointing the bevel pointing that way. It will help to go to the contralateral side. If I want the catheter to land on the right side, I will enter from the left side and point it the other way. So, but if you want certainty, you cannot control left or right. But because of the volume you use, you do have a majority on one side. But both sides is not much motor. At that time, I'm using really dilute like 0.2 ropicaine for 2 or 3 cc an hour. It's not much at all. So it doesn't spread that far away. So I would say still workable, because most of us, if they comfortable thoracic epidural, threading up from thoracic to cervical is really extremely easy, quite reliable. but not from lumbar to thoracic. I think people try it, that people obstetric people try to do it, and they hope that it will go up. It never, because it always hang up in L1 region. But thoracic is different. Thoracic is much easier to throw it on top. It's almost a ESP that there's no resistance to go up.
Thank you, Dr. Sui. We have more than 800 audience hearing to you at this point of time, and we are thankful that you spared your precious time and joined us in this early hours of the morning. I hope you have time to stay with us till we reach the end of the session, and we will be asking more questions as they come in chat box, or we can always leave the message in your chat box and you can get back to us. If it all depends upon your comment.
Yeah, I will be here.
And, thank you, Dr. Sui. And moving ahead, we have all talked about what are the different kinds of blocks which can be done. Now, another important question which comes is, how do we prolong these blocks? So prolongation of duration of regional anesthesia has been a major goal of anesthesiologists performing peripheral nerve blocks, because we are looking at the surgery as well as at the post-operative period. So let's hear what Dr. Ranganathan has to say on this very important topic. Dr. Ranganathan is Director, Regional Anesthesiology and Acute Pain Medicine Fellowship at University of Iowa, and he specializes in ultrasound-guided regional, central neuraxial, and truncal block techniques. Over to you, Dr. Ranganathan.
Hello, good evening, everyone, and thank you very much for providing me this opportunity to participate and present in this webinar. I want to share my screen here. So I don't have any disclosures to make. One thing, the medications used as adjuvants for regional anesthesia blockade, the usage is all off-label, so they're not FDA-approved indications. So drugs used as adjuvants, it's an off-label use. So this is an overview of my presentation. We'll start with what is the current practice, what are the different techniques to prolong analgesia, and what intervention to choose. And then we'll go over the different adjuvants used. There are some controversies and inconsistencies, and there are some volunteer studies done to address these inconsistencies. And at the end, I'll summarize the evidence and we'll look at what direction future research can be done in. So in modern surgical practice, regional anesthesia certainly is the cornerstone for pain management. As we all know, the usage of regional anesthesia techniques and blocks has grown over the years. And the number of blocks have also grown tremendously in the last few years. Why is this happening? The quality of analgesia, which can be achieved with regional anesthesia, is much superior compared to the other modalities. The patient satisfaction is much better. And nowadays, the patient awareness is also great. A lot of patients know that the block is available for their procedure and they want a block to be done. One other significant thing is the decrease in the opioid consumption and the reduction of the opioid-related side effects, which can be achieved by doing a block. One big thing is the opioid epidemic, which has come up, and using the block can prevent patients from using opioids. And there is also a big thrust on discharging patients from the hospitals early. So most of the ERAS protocols in different hospitals always have a component of regional anesthesia in there. And then technology is advanced. There are much better ultrasound and much better needles, which makes doing blocks much easier. And most of the anesthesiologists, they don't have to be specific regional anesthesiologists. Most anesthesiologists can do a lot of blocks these days. So this is the focus of my topic, prolonging regional analgesia. We've been trying to do this for several decades now. What are the common strategies available to us? Continuous catheter techniques have been around for quite some time. And also we've been trying to add adjuvants to single injection blocks to prolong the duration of regional anesthesia. I'll quickly talk about the sustained release local anesthetic molecules. They've been around for close to a decade now. So the liposomal bupivacaine, which has been available here in the US since 2011. And in 2015, it was approved for facial plane blocks or tab blocks. And since 2018, it was approved for interscalene blocks. The one thing is the drug as such is very expensive. Most of the studies have using exparallel liposomal bupivacaine has compared it to placebo. They have not compared liposomal bupivacaine to plain bupivacaine, and when they have compared, the results have not been great. And so most facilities still don't use liposomal bupivacaine. So that leaves us with adjuvants and catheters. So how do we decide what intervention to choose? Two major factors which determine what is necessary are the intensity and the duration of pain. It's mostly related to how big the surgery is. For example, in our institution, we do single injection blocks for arthroscopic shoulder surgeries. And when it's a total shoulder surgery, we do a interscalene catheter. Similarly, we do thoracic epidurals for open thoracotomies, and we do single injection paravertebral blocks for VATS. So overall, single injection peripheral nerve blocks are still the most widely used regional anesthesia techniques. Why is it so? They're sufficient for a vast majority of procedures. They're technically much easier. The skill required is not that much, and they can be quickly performed. They can be done like within 5 to 10 minutes, including the setup time. Catheters take a little longer, and it depends on the facilities you have. And follow-up is also another thing. They're resource and labor intensive. So another thing other than the surgical factors is the patient factor, which is important. Pain management can be difficult in patients who are opioid tolerant, and in chronic pain patients, they may need a little more than a single injection block. And also certain procedures like limb amputations, shoulder arthroplasties, they're hard to manage with single injection block. One other thing which is a significant problem, even in not so major surgeries, is rebound pain. Like with traditional long-acting local anesthetics like ropivacaine or bupivacaine, the blocks last from like anywhere from 12 to 24 hours, and rebound pain can be a significant problem. It can be a big problem if the patient wakes up in the middle of the night because of a block wearing off. So it would be good if you can prolong the block to close to 24 hours. So I think adjuvants do a good job in doing this. And there is always a growing demand for finding a reliable solution to prolong blocks. Before we move on to the perineural adjuvants, I'd like to briefly go over the advantages and disadvantages of the continuous catheter technique. So, as I said earlier, they are resource and labor intensive, need additional cost. The catheters are much more expensive. You'll need a setup and you'll need a service like an acute pain service where you have a team that covers the patients 24 hours, and it's a lot more resource intensive. The time taken to place these procedures is also longer. And in spite of doing all these things, there can be secondary failure, which has been described in several studies. There can be catheter dislodgement, pump malfunction. And in the current era with multimodal analgesia and use of adjuvants, you may get similar results with single injection blocks. The advantages, however, are like if you want analgesia lasting 48 hours or more, catheters are the way to go. And there are studies which have shown benefit of earlier resumption of rehab and physiotherapy. And there are centers which put in catheters and send patients home. So that's another advantage if you have that setup. So now moving on to the main topic here, which is perineural adjuvants. So a variety of adjuvants have been used, and dexamethasone, dexmedetomidine, clonidine, buprenorphine, magnesium, tramadol. They've been used both in neuraxial techniques and in peripheral nerve blocks. I'll restrict my talk here to the peripheral nerve blocks. Several other drugs which have also been tried, epinephrine, other opioids, midazolam, neostigmine, but they have not shown that much benefit, and they are not recommended for use in peripheral nerve blocks. So with so many agents and so many studies, there are more than 1,000 studies on regional nerve blocks and on adjuvants. I'll restrict my talk here to some of the systematic reviews and meta-analyses. So I'll go over some of the important reviews, and I've included most of the more important drugs. So dexamethasone is the most extensively studied adjuvant drug, and it has been used in various routes. So dexamethasone can be used with the local anesthetic during the block as an adjuvant, as a perineural adjuvant. Dexamethasone can be used intravenously. That has been shown to help with pain also. And there are studies which have compared systemic dexamethasone to perineural dexamethasone. I'll start with these reviews which compare perineural versus placebo. Choi and colleagues in this 2014 review, there were more than 800 patients. All blocks were done for brachial plexus blocks, and they found that the dexamethasone increased the duration of action by close to 9 hours with long-acting local anesthetics and about 3 hours with intermediate-acting local anesthetics. And there's another review by Albrecht and colleagues, and they found similar results where the dexamethasone increased the duration of analgesia by 8 hours. And this is another review where they compare various routes of administration of dexamethasone. They compared perineural versus placebo, where the dexamethasone was shown to prolong the analgesia by 6.7 hours. When IV dexamethasone was compared to placebo, even IV, systemic administration of dexamethasone, significantly prolonged the analgesia by about 6 hours. When perineural dexamethasone was compared with IV dexamethasone, the duration of analgesia prolongation was much shorter. It was about 3 hours. So more systematic reviews comparing systemic dexamethasone versus perineural dexamethasone. Overall, you can see by these various reviews, a 3 to 4 hour prolongation of the prolongation of analgesia with perineural dexamethasone compared to systemic dexamethasone. So to summarize and to talk about dexamethasone, it's a potent corticosteroid with anti-inflammatory properties. The mechanism of action inhibits potassium channel mediated discharge from nociceptive C fibers. It reduces ectopic neuronal discharge, and it also attenuates the release of inflammatory mediators. What is the dose to use? Studies have used anywhere between 1 to 10 milligrams. One study showed that the effect of prolongation of analgesia increases in a dose-dependent manner when the dose was increased from 1 to 4 milligrams. 4 milligrams represented the ceiling dose for prolongation of analgesia. Overall, when used with long-acting local anesthetics like bupivacaine or ropivacaine, the duration of analgesia is prolonged by 6 to 8 hours. When systemic administration of dexamethasone was compared to perineural administration, the prolongation of analgesia was about 3 to 4 hours. The second drug which I want to talk about today is dexmedetomidine. This is the other drug which has been extensively studied in the last 10 years or so. In this, we'll just compare perineural dexmedetomidine to placebo. So these are a couple of systematic reviews. One is from 2017, where the dexmedetomidine prolonged the duration of analgesia by 264 minutes. That's between 4 and 5 hours. Both these studies have similar results, where dexmedetomidine prolonged the analgesia by about 4 to 5 hours. There was another review where dexmedetomidine was compared to clonidine, and it was shown to prolong the duration of analgesia by an estimate of 1.2. Another review by Dye and colleagues shows that the duration of analgesia was prolonged by 5 hours, that's about 303 minutes. And another review showing that it prolonged the analgesia by about 3 hours in tab blocks by Sun and colleagues. So dexamethasone, as we all know, is a highly selective alpha-2 agonist. It's about 7 times more selective compared to clonidine. It has centrally mediated analgesia. It has alpha-2 vasoconstrictive properties. It also attenuates the inflammatory response, and it has direct effect on the peripheral nerve as well. What is the dose of dexmedetomidine to use? It's about 1 mic per kilo. Or there was one study which said use of 50 to 60 mics produces optimal analgesia with minimal side effects. Bradycardia and hypotension can be side effects which are reported to be significant in some studies. Compared to placebo as such, the prolongation of analgesia is about 4 to 5 hours with dexmedetomidine. Clonidine was quite popular before dexmedetomidine, and this is a review from 2009, which looked at 20 trials in over 1,000 patients, and the duration of analgesia prolongation with clonidine was about 2 hours. Buprenorphine is another drug which is popular, and the duration of analgesia with buprenorphine was about 8 hours in a systematic review which looked at 600 patients. Buprenorphine can cause the opioid-related side effects, which are like nausea and vomiting, which can be a significant problem in patients. Tramadol is another agent which has been tried again. It can prolong the analgesia by about 2 hours. Similar with magnesium. Magnesium has been tried in several studies, and this review looked at close to 500 patients. And the duration of prolongation of analgesia was about 2 hours. Now coming to the controversy with use of analgesic adjuncts and the regional anesthesia. So several studies have shown that the systemic and perineural adjuncts have had similar effects. So there are number of articles which have shown that the IV administration of dexamethasone and the perineural administration of dexamethasone produced the same result. There was no difference in the effect between the two groups. So this is a recent study which is published in 2020, where they compared the use of 4 milligrams of dexamethasone IV versus perineural, and they did not find any difference. So why are these results inconsistent? The definition of duration of analgesia and the assessment protocols have been very inconsistent in different studies. So that's one reason. They have taken vast course of 3 or 4, the first dose of analgesic use and different parameters. And endpoints frequently occur after working hours, and we have to depend on patient-reported data, which is not a good source. And the blocks are done for different procedures, and the sample size used in these studies are small, which can lead to type 1 errors. And a lot of these articles are published in low-impact journals. So, and these are the reasons for inconsistent results among the studies. So to overcome these inconsistencies, volunteer studies have been done to look at the effect of adjuvants, and dexamethasone has been, a recent study was done where there were 3 groups and volunteers, and dexamethasone was given systemic and perineural, and there was no dexamethasone, and the duration of sensory block was not different between the 3 groups. Dexmedetomidine is the only drug which has shown some effectiveness in the volunteer studies. So it did prolong the duration of sensory blockade significantly in volunteer studies. And clonidine, again, has not shown much promise in volunteer studies. So to conclude, even with the most effective adjuvants, the duration of prolongation of analgesia is just moderate. It's hard to have a single injection block last more than 24 hours, even with the addition of adjuvants. Dexmedetomidine and dexamethasone are the 2 most promising agents. Dexamethasone may give you 6 to 8 hours, and dexmedetomidine will give you 4 to 6 hours. The quality of studies and heterogeneity is great, and that's the reason for inconsistent results. So for future, we need to do combined clinical and basics science studies to understand the mechanisms of actions of these drugs. And also, we should design studies in such a way that we address some of these limitations, where we can not depend so much on the patient reported data, and also have standard definitions for analgesia and assessment protocols. So if you want your analgesia to last for more than 24 hours, continuous catheter techniques are still the better choice. So finally, I'd like to share one study which we conducted here at our institution, where we compared clonidine, dexamethasone, and buprenorphine with a placebo, and we did not find much of a difference. So our study was, we found more variability than expected, and our study was underpowered to detect any difference. That's about it. Thank you.
Thank you, Dr. Ranganath, for enlightening the House on the role of adjuvants in regional anesthesia. We have a couple of questions for you. First one is, what is the dose of dexmedetomidine when used as an additive? What is the dose of dexmedetomidine when used as an additive for a brachial plexus block?
So dose ranges from 50 to 150 mics have been used. The best dose would be about 1 mic per kilo, and like 50 to 60 mics. One study said that 50 to 60 mics produced a desired effect with minimal side effects. So whatever is the best. I've never used more than 100 mics, so I tend to limit to 1 mic per kilo.
Okay, and what is the role of dextran as an adjuvant for regional anesthesia?
Dextran?
Dextran.
I've never used dextran. I've seen some studies being used. I'm not sure about the role of dextran as an adjuvant in regional anesthesia.
So talking about all the adjuvants which you talked about, I know you said that dexmedetomidine is probably the first choice. So in your
and also dexamethasone.
Do you see okay, so if you prefer to use dexmedetomidine over dexamethasone, do you see any sedation also with dexmedetomidine or?
Not really. I don't see that much of an effect. Some bradycardia may be seen, but it's mostly in the intraoperative period. So.
And what is the dose of dexamethasone?
Dexamethasone, the optimal dose quoted is like 4 milligrams for perineural adjuvant dose. So
thank you, Dr. Ramna. Thank you.
Thank you.
Thank you. And, we'll get back to you in the end if we have more questions in our chat box. And we will take, now going ahead, we will take you to a different edge of the spectrum now. Having talked about adults and elderlies, let us move to neonates. And we have with us Dr. Ponde, who will be talking on regional anesthesia in newborn. Dr. Ponde is a focused, innovative, and dynamic anesthesiologist with special interest in pediatric and neonatal anesthesia, ultrasound-guided regional anesthesia in adults, children, and as well as chronic pain management in children. She has pioneered ultrasound-guided regional anesthesia and has been instrumental in establishing the Academy of Regional Anesthesia India on 16th April 2011 to focus on education and research in the field of regional anesthesia. Being highly gifted with communication and organizational skills, Dr. Ponde is the program leader of WFSA Pediatric Regional Anesthesia Fellowship. Over to Dr. Ponde, to you, Dr. Ponde.
Well, thank you. Am I heard?
Yes. Yes, you are audible.
Okay. I'm about to start my screen share. And the screen tells me that I cannot start the screen share. So, yes, thank you.
Can do it now?
Yes, very much. We are on board. Well, thank you. Thank you, Jitender, for the introduction. And I know there has been an avalanche of information since, I think, 4:30, and the neurons are saturated, and perhaps you all are tired listening to a detailed regional anesthesia going, and perhaps not. But let us change the world of regional anesthesia and come to neonatal regional anesthesia as such. Well, you know, a baby is the God's opinion that life must go on, and it is going on pretty vividly, I must say. And having known his opinion, I guess we can be perfect conduits for his expressions as well, if we really think of the superpowers we have given here as regional anesthesiologist over and above pediatric anesthesiologist as such, or anesthesiologist as such. So I declare that I do not have conflict of interest to begin with. I also declare that, yes, I am biased towards whatever I have seen and I am going to talk, and the consents for whatever videos has been obtained for whatever I'm presenting right now. The architecture of my talk is going to be like this. We are just going to look into neonatal pain as such. We are going to see the shift that has happened in the thought process of neonatal anesthesia in particular. We're going to ponder upon why regional anesthesia is so important in today's day and age. Is it really safe now that we are so vociferous about it? We would go to certain case scenarios where regional anesthesia has really helped us out in a big way in this age group. And then we would come to some select everyday block, because every block is out of scope of these 20 minutes. And then we will quickly touch upon what can be done in local systemic toxicity if it had to occur in a neonate. Thankfully, the big debate on whether neonates do have pain is put to rest, and we are very thankful for that. The consequences of acute untreated pain in children, and especially neonate, is staring at us. Other than pain, there are many other systems which can get affected due to acute untreated pain, and hence the importance of this particular topic. I've been inspired, and I keep on getting inspiration from Professor Bosenberg, who initiated the concept actually of regional anesthesia in neonates in a very big way. Well, the paradigm shift that I spoke to you is as follows. Now here is the era where we are actually using regional anesthesia to render operability rather than just an adjuvant in neonatal age group. Under the premise of general anesthesia having been of objectionable benefits, or rather being negative in benefits, such as, it might cause neuroptosis, or it's not 100% as such proved, but there is a chance that we might have CNS effects, negative effects. This has surfaced out even more. This is not just our lookout, but this is the lookout with many other authors as well. Having said this, of course, one has to be reasonably, or not reasonably, one has to reach the expertise of having these blocks well placed and giving the operability that we wish to have. The benefits of regional anesthesia are, of course, avoidance of general anesthetic. So we spare the general anesthesia, avoidance of muscle paralysis as such, if need be. Of course, we go ahead and give it, but it depends upon the surgeries, and all the positive other effects on the neurohumoral effects, the autonomic effects, the gastric motility. And what are, by the way, the other options that we have? We have opioids as one of our options. They are going to increase the postoperative apneas. They are going to decrease the gut motility. And there would be many other effects that epidurals or even any regional anesthetic that we are going to offer going to give. So the benefits of regional anesthesia are very vividly mentioned in this particular review article. So why regional anesthesia? We've just said it gives one of the best pain reliefs that we know of. Its safety profile indeed is proven very well, and it decreases the amount of general anesthetic and particularly opioids. How safe is it? Well, look at the safety. It has been proven time and again with various studies that it is pretty safe even in neonatal population. I wonder where the guardian angel is, because all these blocks are given under light general anesthesia, sedation, or even general anesthesia for that matter. Having this said so well, the safety profile, let us come to the case scenarios as such. Look at this particular case, a day 2 kilogram, baby, male baby with a lot of other issues such as AST, PDA, mild pH, has TOF as well as duodenal atresia. And the surgeon wants to do, in fact, both in one sitting if the general anesthesia and the general condition of the baby permits. So our plan was light general anesthesia with lumbar epidural, and this is how it went. The most interesting part that I would want you to see here is it was, of course, general anesthesia, light general anesthesia in the sense that opioids were not given, and we have had sevoflurane concentration which was far lesser than what otherwise it would have been without an epidural. And the epidural was placed in the lumbar region thanks to a very easy central neuroaxial conduit in this age group, where the drug spread may really not be hampered by any curves which are not yet formed here. And we could actually proceed with the surgery very well with both. Now, what is interesting here is the epidural was extended even beyond, and the baby got extubated in 36 hours after the extensive surgery of thorax as well as the abdomen. So we are banking upon a lot of positive impacts of regional anesthesia in this age group as well. Coming to extrophy of bladders, I haven't yet found a better modality to treat pain in the postoperative period other than actually an epidural. I know Raval sir actually had emphasized on how epidurals are going out of vogue right now. But I guess in this population, if there are surgeries of this extensivity and this invasiveness, and if we are more worried about the painkillers, the side effects of opioids, I guess this is one of the best modalities still working here as such in this age group. Our psychostomy, day 2, again, deranged creatinine, and we can really give a whiff of sevoflurane. This is how we put it. And we could just hold a face mask, whiff of sevoflurane, IV access if it hasn't been secured, give a good caudal block, and let the surgery proceed. So this is how it goes on. Well, we will come to different blocks that can be practiced in neonates, coming to the central neuroaxis blocks. First, again, day-to-day work that I'm trying to share with you here. Hold a mask, but this has to, one keyword again is, you need to be a day in and out pediatric anesthesiologist to see what I am trying to say. Otherwise, we could go ahead, secure the airway, and then go ahead doing these blocks. So a whiff of sevoflurane or whichever sedation we prefer, position of for the block, keep the baby warm and comfortable, and then we go ahead giving a very, very simple caudal epidural or whichever block we decide. Especially when it comes to neonates and hernia surgeries, we are slightly worried about giving ilioinguinal iliohypogastric block, no matter how less the volume of local anesthetic has turned down to be, because these are very, very flimsy tissues, and our surgeons do get a bit flustered with the what should I say, the layers that they go through, and hence I don't think that an uncomfortable surgeon is a very, very good idea. So we do stick to central neuroaxis blocks, at least for these surface surgeries, day in and day out surgeries, such as hernias and circumcisions in neonates. Circumcisions, of course, we have other alternatives, which we shall come to in a short while. Coming back, or getting your attention back to the caudal epidural single shot, it's one of the most simple blocks, very simple, simple to learn, simple to practice, and extremely predictable. It can be easily set, and it's demonstrated that 30 to 35 blocks, and we really can teach our residents this block with pretty exactitudinous. The only thing is they must be learned in bigger children, and then they should be brought to neonatal age group as such. Equipment wise, yes, we could use a hypodermic needle, which is simple, 22 gauge hypodermic needle, or any other needle. A couple of needles have come in picture here, and this is the one which we had used for quite some time, that we felt that it was a little too blunt to actually get into with. So the prick itself gets a little blunter, but then the positive side is it has a stellate, so it does not carry the epidermal tissues right inside the epidural space. So this was a positive aspect of this particular needle. Another one I would like to share with you was the diaphragm that the needle has, and we can actually adjust the placement of it. Hence, it cannot inadvertently be pushed inside the epidural space. So this needle entry is pretty controlled with the diaphragm. Having said this much, we did compare, and we found that the hypodermic needles were in fact a little more better, at least for the introduction. We have not really seen the long-term effects of it though. This is the dose that we use for our usual caudal block. what if I told you that you read the first line wrong? Okay, so this is coming to ultrasound scans of caudal epidurals. Let's look at it like that. It's it's one of the best things you could look at, extremely simple to understand. So if this was the posterior end, this is the anterior, and this is the skin and subcutaneous tissue, this is the sacral cornu that we are talking about. We would be palpating it. We would be seeing it in neonates, in fact, because they're very, very superficial, just underneath the skin, and we would see it under ultrasound guidance as well. Now, having said this, if these are the two sacral cornus, indeed they are, this is the sacrococcygeal membrane, and this is the base of the sacrum. And here you can already see some amount of drug that is deposited. So this is the transverse view. It can be obtained by any high frequency probe. We need not necessarily have the hockey stick probe at all. In fact, I feel the high frequency probe works really well because of the length, and they give a longitudinal section of various spines at the same time, which are very beneficial to see. So this is a hockey stick probe, which I just mentioned to you. And in a longitudinal scan, what we would see is as follows. If this is the caudal end of the patient, and if this is the cephalad end, what we see is the skin and subcutaneous tissue, then these are the spines which aren't ossified, and hence the central neuroaxial conduit is so very open for us to understand what's going on. In fact, if anybody has to understand spine under ultrasound, the most kind place to learn is the pediatric operation theater. So these are the spines, and this is the filum terminale, and this is the base of the sacrum. Okay, just think quickly of all the possible complications that can happen under this particular block, especially in a neonate. We could have the soft base of the sacrum, rather the floor pierced by it. So we could go in the rectum. You can see it if we have kept the probe there. Number one. Number two, it could be an intraosseous injection. If the injection is intraosseous, it is as good as an intravascular injection. So here, another complication that can happen and could be prevented. Number three, we could see the conus right here. So if we keep our needle far below the conus, then of course the dose calculated for caudal can never be injected in the dural sac, and the dramatic complication of apneas after the child is turned supine never happens. Another one complication, which is really very matters a lot when you are anchoring your operability around the block, is a subcutaneous injection. The block shall never act. So these are all the complications that can be avoided in this one particular scan. Having said that, going ahead, we can see the dural sac so well in a preterm baby, and if we go beyond that, we know what would happen. Having said that, this is the conus that we need to really understand if we are going ahead with a spinal. So this is how an ultrasound guidance would aid, or rather real time help us in giving the block. So this is the dural sac that I spoke to you about, and now you would see the needle entering in. So if the needle is too long, and if your trainee is doing it, if the needle is too inside, not inside enough for the dural sac, but inside enough to go towards the anterior epidural space, you could see that as well. Let them adjust the needle to where it should be, and then the drug is injected. Even a small amount of air, which is right there in the hub of the needle, can actually be seen if the flushing is not done to its optimum. So this is the needle again going towards the anterior epidural space, in fact, and this is at the end of the injection. Slightly bigger children, you would see that the filum terminale is here, which is occupying a lot of space, and the injection is already happening. And then there are dural sacs, the posterior and the anterior dura. As such, they kind of move towards each other, and the drug ascends inside the central neuroaxis block. And how much is the ascent depends upon the volume that has been injected here. Well, so I this is just to show you a very pictorial representation of what it could be before the drug and after the drug. So this is the pre-injection, pristine, clear posterior dura, and now the local anesthetic has occupied the posterior dura as such here. I mean, rather sacked the posterior dura and occupied the place here. Well, having said this much as ultrasound, it remains an easy block, the caudal epidural. It remains a landmark guided block. Ultrasound is definitely going to add it. It is going to take away a lot of complications if we are astute enough, but not 100%. But having said this, the success rate as such may not really be hampered if we do not have an ultrasound guidance. We can use this portal in neonates, the caudal epidural portal, to actually go ahead and put in the catheters. From this very portal, we could go to the lumbar area and we could go to the thoracic area as well. The higher thoracic too is pretty reachable through this portal. But if we use catheters, we need to take the complete onus of it on us. We need to have good teams. We need to be extremely in tune and with the NICU people, the NICU staff. Our surgeons should understand what we are doing, and obviously we should be understanding our infusions very, very well. Otherwise, if one thing goes wrong, we would be back to square one, where we would have taken a lot of efforts to put these modalities first in place. So don't venture here unless we have a good team to take care of it. If we really want to see stepwise how it goes, is a 19 gauge epidural needle can be used. It can be used and put in the caudal space by any technique, real-time ultrasound or conventional technique, and go ahead with the catheter insertion. How much catheter insertion is required inside can be calculated or measured by traditionally by centimeters, and we should see to it that the tip is in congruence with the level of surgical incision. This can also be done under real-time ultrasound guidance, and a lot of stories are then revealed. Here is the catheter. We would see it this way, walking up inside the neuroaxial conduit, and it's pretty easy once it goes walking in, because there are no curves here, and the epidural space is the premise is so very congenial. So this is how the epidural is moving up. A little bit of movement tells us exactly where the catheter is. It could go in the anterior epidural space as well, and it might just go out of our vision, telling us that the catheters never take the route that we always think it would take. This is where ultrasound can really help us and to fine-tune the placement of the tips. Through our study, what we found was something more interesting. That it could give more accuracy was something else. But we also found that that age or weight or the level that we wanted to thread the catheter at did not really matter. We have this practice of tunneling catheters, but a good sticking itself, or rather a good skin adhesive itself, would be a good idea as well. What actually is the challenge after keeping the epidural catheter exactly in place? The fine-tuning of the dosages, and we need to calculate our dosages extremely well. So here is an example of 2 kilogram neonate. So 1 ml of 0.1% ropivacaine is one of the simplest epidurals infusions that we could do in the calculation of 0.2 milligram per kilogram per hour. So it would come to 0.4 milligram per kilogram per hour of 0.1% ropivacaine. We need to label it. We need to be very, very sure about the securing of the epidural catheter, and everybody around should know the dosages inside. Without education of the nursing staff and the training around, I don't think this should be practiced at all. Coming to what if we get surprises once we turn the children in the caudal position? Well, there could be discoloration, where there could be hair stuff. So unless we have ultrasound, this is where we should not be venturing. So do a pre-scan. If we see it's all right to venture, intervene. Otherwise, we should be going peripherally. Coming to thoracic levels or epidural levels of or thoracic or lumbar levels of epidural clear cut. Yes, we could, but then again, this should be done by specific pediatric anesthesiologist who always do this job. So it can be 2 people work. So this is the intrathecal space as such. And once the epidural LOR is obtained by saline, because this is what is preferred, we never use air in this population at least. So that's the posterior dura, and here is the local anesthetic, which is now creating space. And we definitely know that we are in the epidural space, which is ready to be threaded with the catheter. Well, we need to be having this modality with us, especially when we encounter something of this kind. This is a case where you will need intense analgesia in the postoperative period. So we could actually go from a higher level with the bevel threaded in the facing the caudal area, and then we threading the catheter down. So coming to trunk blocks as such, I told you my predicament of trunk blocks, but when there are coagulopathies or when there are certain contraindications, yes, we could use the ilioinguinal, iliohypogastric nerve block here for hernia surgery. But in general, in preterm, most of our surgeons do bilateral surgeries. Mostly they might even think of doing laparoscopic surgery. So for laparoscopic surgeries, of course, we could go for the abdominal wall blocks on each side, or we could go for the caudal blocks if we are not too tuned to using these particular blocks. But for open hernias, we really avoid these blocks. Tab blocks, of course, are in vogue now, and yes, can be used. The QLs can be used, but in neonatal population, we really have very little indications for QLs. ESPs, yes, they are indicated, but again, if you ask me, for an exploratory laparotomy, or even, for thoracotomy, yes, but for an exploratory laparotomy, going bilateral, I would rather go to the central neuroaxis. For abdominal wall blocks, if the baby is septic, or if there is a lot of abdominal distension, we would really not demarcate the abdominal layers very clearly. And if the anatomy is not very clear, I probably rather not put a needle there to give a block. Role of upper extremities and lower extremities. Lower extremity blocks may take a back seat, because of course there is a very, very simple caudal to render analgesia and anesthesia there. But upper extremity do have a very, very specific role to play. There may not be very elective surgeries going on, but as pediatric anesthesiologist, you would definitely come across these scenarios wherein ischemia happens due to some inadvertent damage to the artery, and you could be the savior of the arm here. So again, infusions and proper fine tuning is required to reverse the ischemia as such. So you can see here that we have given an intraclavicular catheter. There are other case reports. There is a case report of even subclavian perivascular catheter being kept for quite a few days, in fact, for repeated dressings in the ward for a fasciotomy. We had a septic baby where we needed to drain the pus from the shoulder as such. So a subclavian perivascular block with just a whiff of sevoflurane could do our work here. You can see the heart rate of the child, and you could see the subclavian artery here. And we did not have a hockey stick probe, but yes, as I told you, if we are used to the modality, hardly ever, say 0.5 or 1 ml of local anesthetic injected in a subclavian perivascular area does give enough analgesia or even operability for a surgery of this kind. Day-to-day work, which is circumcision. Now here is another premise where we would want not to give general anesthesia as such. The challenge is to keep the baby extremely comfortable, extremely pain-free. at the same time, be very, very open to the fact that, look, our block is not working, do something more. So the plan B has to be very clear. But this is how we do our day-to-day work. So this is a baby suckling actually on sucrose, and a ring block is given. What we could do is, now, after the ring block is given, wait for the block to act and then proceed with the surgery. Usually this happens and it's very seldom that we really go ahead and give a general anesthesia in these particular cases. So the operation theater is kept warm. The drugs are aspirated to begin with. The child is kept very comfortable. And after waiting for the block soakage, this can be done. So you could give a ring block, or you could give a dorsal penile block. But of course, if you give a dorsal penile block, we do inject on the ventral side as well. Spinals, yes, spinals in preterms or in very sick babies, they can be used. We do not support the use of spinal unless and until we do not have any other choice as such, for certain reasons, as it wears off very soon. It does not linger in the postoperative period. The analgesia does not linger in the postoperative period. A bilateral herniatomy for something which the baby might come on table in the first place may not be over in, say, 90 minutes. Hence our reasons of still going towards caudal block, which can be made as strong or as beneficial as a spinal and gives equal operability. So local anesthetic systemic toxicity, yes, this can happen. This can happen as in any other case. So we need to be very, very sure about our plan at such times. So we ensure an adequate airway, provide ventilation and supplemental oxygen, institute cardiopulmonary resuscitation at the first instant, do use intralipid 20%, 1.5 ml per kilogram over a period of 1 minute, repeat every 3 to 5 minutes, and if successful, initiate 20% intralipid infusion at the rate which is around 0.25 ml per kg per minute, and propofol is dangerous. So this in nutshell is what neonates and regional anesthesia can do to each other. So it's pretty beneficial, provided the indications are fitting. We really have a lot of experience in handling neonates, and we have a good team to take care of the blocks that happen. Then lots can be done in this particular specialty. Thank you.
Thank you, Dr. Varushali, for highlighting regional anesthesia in specialized population and disclosing the tips and tricks there. We have a couple of questions for you. The first one is that in case one which you talked about, you said that you managed epidural for 48 hours. So what did you use, a continuous infusion or a bolus, and what was the dose you used?
Yes, to begin with, it was a general anesthesia plus epidural infusion. Yes, it was a bolus, and it was a bolus for good 48 hours. And the bolus was not titrated as such, but it was calculated in the calculation that was written.
Okay, so it was per kg.
The infusion was calculated as 0.2 milligram per kilogram per hour of ropivacaine, which is in the concentration of 0.1%.
And what adjuvant should be preferred for neonatal caudal blocks?
If at all we do not really use many adjuvants, or rather any adjuvants. If at all we use, it is always clonidine.
Okay.
And
one last question. Yes, sir, please.
Can I say something on this?
You're welcome, Dr. Karmakar.
I think, Varushali, that was a great talk. I just want to add some of my perspectives as an additive, I think. I think for those who are not familiar with this, just remember in neonates, in small infants, you never use more than 0.1% of whatever local anesthetic you are familiar with. One, you should never start with more than 0.1 mils per kilo per hour. The third thing is, imagine your baby is 2.5 kilos, you have to give 0.25 ml. I bet in 99% of the time, you do not have an infusion pump that is accurate enough to deliver that low volume infusion. So if you are contemplating on using infusions, then you have to have very specialized infusion pumps. And there are only about 2 or 3 companies in this world. So it is not as easy as just saying I can put a catheter, run 0.1% and run an infusion. Secondly, this must always be done as a team effort. Your role in the operating room is to be followed by people in the neonatal intensive care. As Roshali said, if you do not do so and you just send somebody with a catheter, which you probably in your right mind would never do so, but if you do it on an occasional basis, this is a recipe for disaster. So my thoughts are that when we use continuous infusions in neonates, it should be mostly in well-equipped hospitals like PGI Chandigarh or some very well equipped centers where they have backups, they have follow-ups where they can be followed up, etc. Another word about running the infusions. I think Vishali said 48 hours. That is very true. This is based on evidence from early 1990s from Boston Children's Hospital that because most of the catheters are placed via the caudal route, irrespective of the number of days, most of the catheters are contaminated with gram-negative organisms. Now, just because there is a culture of a gram-negative organism does not lead to a positive meningitis or an infection. But if you leave the catheters more than 48 hours, the chances of infection go proportionately very high. So catheters are left for 48 hours and no more. Finally, local anesthetic systemic accumulation is a big problem in neonates. So one must not plan your epidurals in these children lightly. You must take it very seriously because these children have low albumins, they have low alpha-1 glycoproteins, they are prone to have systemic accumulation, they have immature livers, immature kidneys. The total concentrations and the free concentration of local anesthetics go up exponentially after 24 hours of infusion. So if you are considering running an infusion more than 24 hours, our practice is to run 0.1 mil per kilo per hour. And based on the response of the child, usually tailor it down. So that means you can imagine you're running 0.3 ml, and we are running somewhere between 0.1 and 0.2 ml. Now, this is in the context of a very segmentally placed catheters. Not many people talk about Dr. Ben Sui's contribution in this area. In my hospital, all residents I train, all my fellows we train, we do not put thoracic epidural catheters without epidural stimulation. That's the bottom line, because epidural stimulations in conjunction with ultrasound gives you the control that you can place the catheter in a desired level with no more accuracy and safety. You can also exclude intrathecal, inadvertent intrathecal placement very easily. And if you have a segmental catheter, you do not need more than 0.1 mil per kilo per hour. And this circumvents some of the associated complications, etc., that I alluded to. Finally, as a critique, because we are all colleagues, so I like to critique one of the images that Roshali showed, and I hope none of you in the audience or in as a trainee would ever do so, is when you do a caudal block, you do not want to see the needle so far in the caudal epidural space. The idea is to access the caudal epidural space with the needle, not to enter the anterior epidural space. Because the thecal sac, in most cases, you could see in the images, go all the way up to S3. So if your needle is more than a centimeter or so in the epidural space, it's very easy to to puncture the thecal sac. Now, you may say, oh, I can do an injection and determine if it's an epidural or intrathecal. I can tell you determining an intrathecal injection, even with ultrasound, is almost impossible. Again, Ben Sui is here today, and he has done some work really looking at caudal epidurals using Doppler ultrasound, etc., looking at how you can determine epidural. But he would agree that the rate of infusion that they were injection that they were using to determine epidurals injections were way higher than what you would normally use if you did spinal injections. Spinal injections in young children, we hardly inject more than 0.1 mil, 0.3 to 0.5 mils per kilo per hour if you did it deliberately.
Well,
Finally, I don't think there is, we have gone away from doing intrathecal injections in young neonates, even for hernias, etc., because the trouble that you go through it is too much. The surgery lasts longer, and the fight that you get, you know, the trouble you get involved with, eventually you'll end up intubating the patient. I think caudal epidural catheters, as Vrshali also alluded to, should be the first line of management. You can put a caudal epidural catheter in a neonate or very easily, and this can be used for periods as long as even 2 hours. We have done it in some cases. So with the advent of ultrasound, I think the caudal epidural catheter has become very objective, very safe, very simple, and you can pretty much forget about doing intrathecal injections. That's what I would write in my book.
yeah, that was an amazing session of comments. I would rather address just two things from my own practice. Number one was, yes, Professor Karmarkar very aptly said that we could use stimulation technique, and I have actually Dr. Bansoi sitting here saying, listening to this. I also have a video of the same in the presentation, but I kept it aside a bit because I thought that if the neuroaxial conduit is so open in front of us, and if we can see the movement of the tip, and if not the movement of the tip, at least the spread of the local anesthetic, maybe we could keep the cost benefit, the cost of the catheter, the stimulating catheter costs a bit here in India, and we would not add on to it unless and until it's indicated a lot. So I would keep that in a difficult back or a scoliotic kid. So where I would not get a good ultrasound image, or maybe beyond 3 months, where I'm not too sure of the visualization. Even in 3 months, it's visualized pretty well. Of course, these are my thoughts. Number two, the anterior placement of the needle, or the needle going too inside to be in the anterior epidural space. I absolutely agree with the comment of Professor Karmarkar, but this was a video shown to a trainee for him to himself that this is what can happen in a small baby. So while he had put the needle inside, the image was shown to that person, and then the needle was withdrawn and the injection was performed. So ultrasound actually can be taken as a very good teaching tool, because finally we need to teach, and then they can be bought from 5-year-olds to 1-year-olds to infants to neonates, and then finally to preterms, because they do a fellowship of a year with us. So these were the two. The added comments that were given on the infusion pump, I just couldn't agree more with you, Professor. Yes, if there is no team, it simply should not be put. Yeah, and in fact, our thought process is like that. If we keep if our calculations tell us that it should be 0.5 ml per kilogram, say maybe in a 4-kilogram baby, then, and if we put say 10 mLs of the syringe, then it should go at least for 20 hours. And then we also have certain issues. It's not actually an issue, a back leak of the epidural of the drug that comes in. And that obviously, again, our team understands that there is going to be a back leak, and we accept that back leak because we also know that what is required generally seeps in. Thank you.
Also, I think with respect to adjuvants, there is no evidence on the efficacy of adjuvants.
Yes.
That's the bottom line.
Yes.
And I think in my principle is, and this is what I teach the people who do pediatric units, I say keep it simple and stupid.
Absolutely.
You'll never go wrong.
Yes.
So unless you add these funny things, you are going to have a safe sailing anesthesia. And when you look at looking after kids that small, that will give you more peaceful sleeps. Put it that way.
Yes, and here the entire thought process is to go away from many drugs, and just to keep it simple, take your regional anesthesia and see to that it gives operability. That would be the main thought process behind selecting a regional block in this population, at least currently.
One last question for you, Dr. Vaishali.
Yes,
what size epidural catheter do you use in, caudal catheters do you use in
We have
neonatal?
19 gauge with us. Although, however, there are 20 gauges as well, but we stick to 19.
Okay, and how much do
Most
you
of the
leave it
times,
inside?
unless it is, yeah, how much depends upon what surgery it is.
Okay. Okay, so we will have one quick round of questions. We have a number of questions piling up, but we'll just ask one for each of the speakers, faculty, and then we'll let you go for today. So we have a question for Dr. Karmakar. Is there any chance of sparing the C6 route in selective upper trunk block due to muscle sleeve injection, due to muscle sleeve coming in between C5 and C6 trunk? Are you there, Dr. Karmakar?
Yes, I am here. I think that's a good question. Now, before I showed you that ultrasound image, you probably wouldn't have thought about that. But now that I've showed you the muscle bridges between the ventral roots, so I think between the ventral roots of the various brachial plexus roots, you are now starting to think about it. Now, when you do your brachial plexus injections, the injections are usually more distal to where you see the bridges in relation to the transverse processes. So in clinical practice, the bridges may influence spread from one level of injection to another, but I don't think it will ever affect the overall efficacy of the block that you're performing, unless you are doing a block that is more medial. And if you're an anesthesiologist, you have no business doing an injection there. So let me put it that way. If you're a pain physician, maybe you have business to do an injection close to the foramen. As an anesthesiologist, we have no business. So I think I will shut that discussion down there.
Okay, and Dr. Sui, a question is that will flushing of, if you have a local anesthetic toxicity and you use normal saline to flush, reverse the effect of local anesthetic, will the reaction of, with the effect of local anesthetic as analgesia also get reversed? And then how do you go about from there in these patients?
Okay, as I showed, maybe like we rush in a way, but actually we demonstrate that the saline first we're using for only able to reverse the phrenic nerve. In our study, we're not able to reverse the brachial plexus. And also another study we conducted by my former fellow in New Zealand also show that even you aggressively washing, you cannot wash off the sciatic nerve. Now, as I say, the main reason probably because the phrenic nerve is small in diameter, so you can the expose of a mass saline dilutional effect, and also the nerve is different from all the brachial plexus or other nerve because it's always active. Your CNS always trying to fire off so that you can take a breath all the time, particularly you're in distress. So that may be a reason why we so-called the old day, we're talking about frequency dependent block more often and wear off more often. So now to safeguard all that, when we go through the ethics committee, because if you wash it off with the catheter, you can always bolus back to regain the analgesic effect. But so far we don't have that problem.
Dr. Raval, what are the recommendations for the role of epidural in open gynecological surgeries, oncological surgeries, as per IRAS prospect guidelines?
Yeah, sure. Before I answer, I mentioned that about this chewing gum, and I think I mentioned that for the colorectal surgery, ERAS guidelines, it is 10 minutes of chewing gum 3 or 4 times a day, preferably sugar-free chewing gum. So regarding the guidelines for gynecological surgery, for cancer surgery, is that what you're saying?
Yes, sir.
Well, there are no specific guidelines for, as we said, I can mention what Prospect is saying. And we have not looked at that particular procedure. We have looked at hysterectomies and we have looked at C-section in that area. But what we are generally saying, as I showed in my slide, also, by and large, epidural is out. And so, and also to Brachial, who mentioned about my being a kind of anti-epidural. I must say there are some indications for epidural. They are going down, but I would not say anything in your particular scenario where you are talking about the neonates and also very extensive surgery, and we do not have very good alternatives. My lecture was about in adults, so I would not dare to go into that section, and I would definitely go, you have and in general, when you have epidural, and if you do audits and you are used and you have fine-tuned the technique over the years, I would not go away from it and start using experimental techniques that are coming. So going back to your question, again, as I said, I would not be using epidural unless it is very major, open, extensive surgery. There you have some evidence that epidural might help. But as other speakers have also said today, there is increasing evidence that epidural not only is not beneficial, it can in fact cause harm, particularly in the ERAS scenarios where we want our patients to be mobilized. And if you're going to use epidurals, and again, I would recommend that we do audits. Unfortunately, people don't do audits. A good, successful epidural is a so-called walking epidural, which we've been doing for decades for the pregnant patient. So you can have an epidural and the patient is up and about and is mobilized. So to me, a successful epidural is, if you're going to put an epidural in the kind of surgery you're talking about, a major surgery, then you have an epidural for maybe 2 days or 3 days. And a successful epidural is one which allows you to be relatively or pretty pain-free, because when it is good, it is fantastic epidural. But the patient has to be mobilized. And so you have to balance that so you don't have urinary retention, you don't have hypotensive episodes. And also, like one of the other speakers mentioned, we have not discussed about the costs of epidural. Unfortunately, the costs in terms of serious neurological complications and other costs are higher than what we have believed in the past, and the benefits are not as great as we have believed in the past. So that is what I would say. Today we have good alternatives to epidural, which are also evidence-based. So that is what I would say. But answer specifically your question for that particular procedure, I cannot say, because there are no such published guidelines as far as I know.
Thank you, sir. We have another question which can be left open to the hall, but I think it fell more in the domain of Dr. Uppal. So, Dr. Uppal, between IPAC versus periarticular block, which one do you think is more effective? Do we have you here, Dr. Uppal?
Sure. Yeah, no, I was trying to unmute myself. So, so I think we're going to knee analgesia now. Is that correct?
Yeah. Yeah.
So
I thought you were hip and close to me. Dr. Kamakar was far off. We had to move him from the brachial.
So I can answer that question, but it'll be good to get others' opinion as well. So I was doing a book chapter a few months ago, and the evidence on IPAC was very limited. But recently, I've seen a lot of papers on IPAC. So I suppose the evidence has changed within last few months drastically. In our practice, and I can tell you about practice, I think what we're question is comparing periarticular infiltration with IPAC.
Yeah.
So we have to understand this, that periarticular infiltration will get all the small nerves, if done accurately, around. And knee is slightly complex in the sense it's got branches from femoral, it's got branches from sciatic, it's got branches from obturator. So just comparing IPAC with periarticular infiltration, I feel is an unfair comparison. If you have to compare periarticular infiltration, you have to compare it with all these other modalities. So like you have to combine it with, at least with the adductor canal block and IPAC with local infiltration analgesia. And I don't know what is, if it is as good as it not, but I don't see a downside of using periarticular infiltration. It's a very low risk technique. It's doesn't require time. Surgeons can do it intraoperatively. But having said that, adding adductor canal block actually makes sense because it's been shown to improve outcomes from analgesia and PONV point of view as well. So this is a long-winded answer, and I'm not sure if I've really got to what the person who was asking the question is asking. But in our practice, we do IPAC for specific surgeons who don't do periarticular infiltration. And most of our surgeons do periarticular infiltration, and we do offer adductor canal block on top of that because it has been shown from multiple systematic reviews now that adding adductor canal block, which is a motor sparing block, to periarticular infiltration improves outcome.
We have Dr. Raval. Dr. Raval wants to say, sir, you want to say something?
Just a very quick comment. I totally agree with you. And the point I'm making is about total knee, because we've been debating it in the prospect group because we have not updated for several years. Total hip is online any day now, and the knee is the next one. And so we've been debating in the group. And if you look at the literature, I'm not talking about IPAC, and it's not as well documented, but if you look at the literature, there is very much evidence about the LIA technique. And again, I think, as I mentioned in my lecture, there is some confusion about LIA and local infiltration, because LIA is local infiltration, but what LIA we are talking about is periarticular, which is only for hip and knee. And the evidence there is for this periarticular technique and sometimes with adductor canal block. But with IPAC, I have heard from many people it's very effective, but there's not as much literature. So I agree with what was mentioned. Thank you.
Thank you, Dr. Raval. Thank you, Dr. Uppal. With that, I will hand over the mic to Professor Kajal Jain, and we will conclude for the day today. Thank you.
Thank you very much. Today has been a very good day, an exceptional academic feast to all of us. And I feel very honored to have such luminaries on board with us. From the organizing team here at PGI Chandigarh, I extend a heartfelt thanks to all our faculties who constantly answered the queries coming into the chat box every few minutes. And here back in the preview room, we were trying to sort them out, assemble them into one and present it to you all. So I really thank you all for the big support you have lent us. And we had close to 1,400 registrations at a particular time. We had 800 people viewing the session. So I feel very good about that too. And so we assemble tomorrow again at Indian time, 8:45 a.m. So just to conclude, as has been the ritual in India, can we all rise up for national anthem and give it a concluding touch? Can we have the cameras on so that we can, record it for future reference? Thank you very much.
नहीं होने वाला है। I don't hear anything. I don't hear the national anthem.
It's coming, sir.
Okay.
It's coming, sir.
Okay.
Thank you, everybody.
Thank you very much,
Thank you, sir.
everybody.
Thank you very much, sir.
Thank you. Thank you. See you all tomorrow again.